And as a part of your practice coming up, before you started running your own practice at Treehouse Pediatrics, did you have the occasion to see people with various viruses and diseases and things like that?
Most definitely, constantly.
And those were in what, both adults and children, or mainly just children?
In medical school, we were amazingly exposed to just about everything. I delivered over 150 babies at the University of Alabama School of Medicine. We did internal medicine rotations, geriatric divisions. While I was at Winter Garden Children's Health Center, I worked with an amazing man, Dr. Orizondo, and helped with some of his adult patients as well.
Okay. Dr. Nielsen, I should have covered this at the beginning. You're in your office. That's why you're wearing a mask, I assume.
It is. Unfortunately, my staff has had an exposure, not recently, or we had an outbreak, quite frankly.
Okay.
12 people were exposed. They did become sick and infected. And so since we know we don't have the appropriate air conditioning vents here in a commercial plaza, we've chosen to all continue to wear our masks while we're in the building. We only take them off when we're outside.
Perfect. I think that jumps into another area I wanted to cover with you, Dr. Nielsen. What precautions is your office taking due to COVID-19?
That's a great question. So when we get up in the morning, when you get ready to get in your car, you have two pairs of shoes that you know you're going to wear that day. You have one pair of shoes that you wear in your car. You wear that till you get to the office. You take them off, and then you put on the pair of shoes that you're going to wear at work. Because we know that this virus can live on surfaces, and kids are germy little boogery people, God love them, and things get everywhere. So if you're going to go back home, you don't want to wear those same shoes back into your house. Also, like this, I'm wearing this surgical mask. But when we see our sick patients, we're actually seeing them outside in the back alley of this commercial plaza, underneath a 10 by 10 tent. Out there, it's about 100 degrees today on the blacktop, if not a little hotter. So earlier today, I had on an N95 mask, my face shield, a gown, gloves, different shoes for out there as well. And it gets really hot, but it's how you know you're safe. And then when you come back inside from there, you take all that off, and then you have to hand sanitize head to toe any exposed body part.
You mentioned that you had an outbreak in your office.
Mm-hmm.
Did you have these same precautions going on or similar precautions going on at the time you had the outbreak?
The only thing that we didn't have in place was that my staff would sit in a 14 by 14 lunchroom around two 8-foot long tables, basically the kind you get at Walmart that are just cheap desktop tables. And they would sit there and they would eat. Other than that, these exact same precautions were kept in place. The exposure happened because we had an irritable parent who was out back with their sick child who refused to wear a mask. They coughed, they sneezed. We got a phone call from the father a couple of days later saying that the mom had gotten her test that was the result that was positive. However, she had been tested before she came to our office that day with her child. She lied and she said she had not been, but she was. And that is actually where the exposure happened.
As a result of some of your staff members getting COVID-19, what were some of their symptoms?
They've had everything from runny nose, cough, loss of smell, loss of taste. Two of them still have that going on. And that was on July the 22nd that actually happened. One person has a cardiac arrhythmia. Their heart rate is now consistently down in the 30s. It should be in the 60s to the 80s. Another person has chronic hip and joint and achy pains, fatigue. Her mobility and motility around the office is greatly reduced and decreased. Another person still is having diarrhea and horrible stomach pains. And again, that was July the 22nd. Some people still get headaches, blurry vision, dizziness.
So about a month later, we're still seeing effects from the virus. Yes. Have you treated patients with COVID-19 as well?
Yes, I have. Actually, just this morning, I had an 11-year-old come in. He was complaining of ear pain, but as a routine now, we also check your oxygen level. His oxygen level was 93%. We asked him how he felt. He said he felt kind of weird. That Sunday night, he kind of had black dizzy spots in his eyes, and he was scared to tell his mom because his mom works at the airport. And if his mom can't go to work, he didn't know how things were going to go down because he didn't know if his dad could stay home from work. Well, at 93%, he's not moving enough air to keep himself saturated and healthy. I have a higher oxygen concentration with my mask on all day than that. Mine stays at 99, and I have severe asthma. So with that little guy, we went ahead and tested him for COVID here, and we went ahead and sent him for a chest x-ray. He is positive. And thankfully, we tested his oxygen level. And so now we'll deal with that and keep him healthy. We've also had a 15-year-old girl who came in with the worst headache of her life. We sent her to a local emergency room. That local emergency room discounted that and said that she was simply overly medicated on Benadryl and another medicine used for migraine headaches. She went back home later that night. She was unable to speak and swallow. She stood up, walked blindly to her mother's bedside. Her mother screamed, called 911, took her back to the original ER, unfortunately. There, she was ultimately admitted and diagnosed with a complete left-sided brain stroke. So she stroked out the left side of her brain completely. That left her nonverbal, not able to eat, not able to talk, not able to walk. That's pretty bad when you're a 15-year-old straight A student with no pre-existing conditions. That's unacceptable. So she had a full hematology oncology workup that was done in the hospital and completed here at the office. She has no hematological risk factors for coagulation. However, her COVID was positive. So we've had numerous ones. We had a 9-month-old baby who came in because the mom had just been admitted to the ER and was being admitted to the ICU at a local hospital. That 9-month-old baby had a runny nose, and dad was just worried since mom was going in the house, to the hospital, in other words. So dad came in, he to the back. We ended up swabbing dad, the 9-month-old, the 17-year-old, and the 9-year-old that were all in the car. Dad, the baby, and the 17-year-old were also positive. The 9-year-old was not positive at that point, but 4 days later was positive as well. So household spread is happening as well. I also have a patient who, the girlfriend was a dance member of a local high school dance team. At that point, the girl did not know she had been exposed. So she was hanging out with her boyfriend who's 16. And you know, when you're 16, you make out. So needless to say, the boyfriend got sick. One Sunday, they went to the grandparents' house. The grandmother's 86 years old. She has COPD, emphysema. She's on oxygen, severe lung restrictions. And so the boyfriend says, oh my gosh, I'm sick the next day. I have a fever. I'm coughing. I can't breathe. They come in. We check the boyfriend. We check the girlfriend. We check the mom and the grandparents. The boyfriend and the girlfriend both have it, although the girlfriend remained asymptomatic. The boyfriend had a severe case. The grandmother ended up getting ill, as did the boyfriend's mother. So we've had several cases.
Perfect.
And we're
Let
one
me
of the
go back.
pediatric offices testing, which is sad.
Perfect. Let me go back just for a second, Dr. Nielsen, and cover a couple things you went over. I appreciate you going through some of those patients. The patient that you mentioned that tested positive for COVID-19 and ended up with a left-sided brain stroke. Mm-hmm. I assume you've reviewed her chart.
Completely.
And was there any other cause that you can determine other than COVID-19?
There is none. We did a full hematological evaluation because if you're going to have a clot, if you're going to stroke, it's presumed that you're going to have thick blood, or you're going to have a platelet issue or a clotting issue or a blood vessel with a kink in it, kind of like a hose when you put your finger over the end of a hose and you make it spew everywhere. Well, this kid had none of that. She had normal blood vessels. She had normal clotting factors. She had no issues with her clotting issues at all. The only thing that she had was COVID. No other infection, and she was tested for everything.
Let me go back to another one of the patients you mentioned. It was a family. Mm-hmm. The question I have for you is, based on your experience that you've had with these patients, are you seeing this spread from child to adult and adult to child?
Yes. Yes, indeed we are.
Okay. So, as a part of your testimony, doctor, and let's jump back just for a second, I assume you've reviewed some materials.
Yeah.
Not only for your testimony, but just for your practice. Mm-hmm. And would those include CDC guidelines, updates from the American Academy of Pediatrics and things like that?
Yes.
Okay. I believe there's even a white paper put out by the American Academy of Pediatrics.
Yes, the Florida Association of the American Academy of Pediatrics worked together with the AAP to put out a complete white paper, which are their recommendations and feelings of what should be happening with COVID and schools as we move forward. Because they didn't feel like they were getting that the pediatricians and the healthcare individuals themselves were getting any good direction from anywhere else. So they felt it was time to go forth and put forth some recommendations.
And Dr. Nielsen, we've heard sometimes in the media that children are less susceptible to getting the virus. Based on your experience and your research, is that something that you've noticed as well? Or has that essentially been debunked?
I think that's been debunked. So if you think about what happened on March the 13th, I remember going up my stairs at my house, looking at my son who was sleeping in a tent and mad at me because he couldn't go to spring break camp. I remember telling him, I'm so sorry, babe, but I guess today's the day the world has changed a little bit, because it had changed. Suddenly we were keeping our kids home. They weren't going on their spring break trip. They weren't going to camp. They weren't going to go to grandma's to spend the night. They weren't going to go on a cruise. I remember breaking that news to a dear friend of mine. No, you're not going to take your kids on the cruise because I don't know if you're coming back. And I wasn't ready to lose her as a friend. I'm still not. So I think you have to think about it. If you keep everybody home, and we as parents, we're great. We're going to protect our kids because it's what we do. They're our future. They're our life. That's who we live for. The day you're handed a baby, your heart lives outside of your body for the rest of your life. So we protected our kids and we kept them closed in. If a child has no risk factor and is not exposed to anything, they're not going to get sick. But what did we do this summer? We sent them to the St. Cloud Community Camp. We sent them to the pool. We sent them to soccer camp. And what happened to that St. Cloud Community Day Camp? It closed down after everybody got infected. That was actually part of what originally was thought of as a slow progression of how you could open things back up. Well, it got disproven right there. We tested over 30 kids that week. They were all positive. And they all got it from the same summer camp, from the same little counselor person. God love them. So I think if you keep kids away from infection, yes, they're going to be healthy. But if you allow them to get together and play in an area that's closer than 6 feet without a mask on, they're going to spread it. And I think that's what we're seeing now. That's what you're seeing, even at UNC that just got shut down this week. Colleges are having that problem. Schools in Georgia are having that problem. You put kids together, they get sick. You keep them apart, they don't.
So Dr. Nielsen, I want to hit on a couple topics that you just went over. And number one, I want to talk about, you've seen this spread amongst people, amongst children, amongst adults. Do you have to, some basic questions that I think people might want to know. Do you have to have a fever to spread COVID-19?
Not at all. The girlfriend of the boy who got it, she didn't have any symptoms at all.
And can you define what asymptomatic means?
It means you have the virus in you, but you may simply not have any symptoms yet. So even like when you get strep throat, before you get strep throat, before you have that 104 fever and that horrible sore throat, it's in you. You only have a fever if enough white blood cells, your soldiers in your blood, have decided it's time to rev up and fight. That's what makes a fever. So if your white blood cells are going, we're not going to do anything just yet, you're not going to have a fever, but you'll still have strep throat and you're still contagious. The same is true with this. If your white blood cells have not revved up enough, then you're not going to have a fever, but you're still contagious. The flu works the same way.
I understand, doctor. Let's go back to some of those patients, and then I want to go into a different topic. The patients that you've seen with COVID-19, have you seen some as early as, let's say, March or April? And do those patients still have any lasting effects from this virus?
I think our first one was the second week of March. It was right around the 10th. It was right before spring break. We knew about COVID because I'm kind of a research geek, and I think my med school instilled that in me, be a lifelong learner. Thanks, Dr. Boulware. So I think that, that was our first one. We tested them. They were positive. That child does still have some symptoms. That child still has some achiness and fatigue. And I still am seeing it, of course, in my staff as well. The 15-year-old who I mentioned who had a stroke, she's going to have lifelong complications, even with the best and most aggressive therapy, unfortunately.
Perfect. I want to jump into another topic with you, Dr. Nielsen. You were fortunate enough to be asked to join a medical advisory panel for Orange County Public Schools. Is that right?
Yes, I was.
Were you given specific directives on what to do when you joined that medical advisory panel?
When we were first joined, we were told that we were being asked to do this so that we could give the board the best scientific evidence and the best ideas and the best medicine, the current issues. In doing so, though, in our first meeting, we were also instructed, though, that unfortunately, due to funding considerations, not opening after August the 31st was not an option. If you opened after August 31st, the schools weren't going to have the funding. And that was going to be devastating. And that wasn't something they were willing to entertain. So we had a constraint of time work that we had to work with, a time frame we had to work in to figure out how we were going to suggest opening it. At that first meeting, none of us felt that we should be opening schools. And we kind of still were at that point most recently. We did go ahead and say at our last meeting that, we could try opening our elementary schools, but hold off on your middle schools and your high schools, because the information we have and the scientific research shows that right now, 10-year-olds and up spread it just like an adult. Your viral load in your younger kids is high, but because they don't cough as forcefully, the spread may not be as fast or as rapid. By only allowing elementary to open up initially, we were also hoping that the schools would have time to improve their safety procedures and protocols. We know that there's issues between different types of masks. It's recently come out that the gator style mask is ineffective and inappropriate to be used in a school setting. However, that's still not delineated in the safety manual that OCPS has put out. That's something that we're actually going to be talking about this evening, I believe. Okay. In addition to that, we went ahead and said, you need to have robust testing, because without robust testing and contact tracing, you're going to have an ineffective system as well.
Let's talk about a couple things. As a part of the medical advisory panel, were you provided at any point with the Department of Education's Reopening CARES Act Florida, which I believe may have been back in May?
We were not.
Okay. Have you since had a chance to review that as a part of defense's exhibits?
I have.
Okay. And if you can just give me a brief summary of what you noted in that, I assume it was a PowerPoint presentation, is what it looked like to me.
It is. That's what I looked up when I was looking just through documents with CDC and things. I noticed that page 36 through 71, so 35 pages of a 143-page manual, actually dealt with health and safety of children. I thought that was pretty sad. On page 36, it said reopening will require locally driven strategies, guidance from the Department of Education, Department of Health, DCF, and the Department of Emergency Management and local health officials. Unfortunately, our local health official, Dr. Pino, was not willing to give the board directive as to how that should be handled. We did invite Dr. Pino to one of our MAC meetings, our Medical Advisory Committee meetings. However, Dr. Pino again said, his answer when I asked the question, should we open? He said, if you'd asked me that a month ago, I would have said no. Well, maybe I should have asked him a month ago instead of the board asking him. On page 37, it said to use this document as points and to consider and implement with local context, knowing that there's not a perfect formula. That's actually true. You should be opening this gently with local context because there's not a perfect formula. They say it right there. Plans to reopen don't need to mirror each other. That's true. Plans cannot mirror each other. Every county is a different beast. If you look at Orange County, our numbers are high. If you look at some other counties, their numbers are lower. So it's not going to be a one size fits all. Just like, a shoe isn't a one size fits all. You got to figure out what fits your area. So if we at Fort Walton Beach, for instance, with hardly any, positivity, well, okay, let's let Fort Walton Beach open if they're ready. But don't force Orange County, don't force Hillsborough because they aren't ready. You set it in your own document. Do it. They don't have to mirror each other. Page 41, adhere to the guidelines from the CDC, state and local health department. Do that dimmer switch approach. And if it fails, reconsider things. Well, that's what that Osceola County St. Cloud day camp had happen to them. They did the dimmer switch approach. It failed. They're still going to open up on August the 24th. Page 51, it recommends to redesign the school day to make it feasible and to consider and to explore things like masks and hand washing. They don't say wear a mask. They say consider it. Should you consider hitting somebody? No, you just shouldn't do it. Let's just be honest, guys. It said at a minimum, schools should be supportive of voluntarily having people wear cloth face masks. Again, that's old data. When I was a resident, if a doctor wrote an order, the newest order knocked out all preceding orders. So that's the other problem, but I'll get to that in a second. Page 59, the CDC disclaimer of the importance of local context should be noted. Well, the CDC is saying that Florida has too many cases to open. Page 62, consider a contact tracing protocol. Consider it, don't do it. Y'all, that just doesn't make any sense. God love them. Page 63, consider a testing protocol. We're in a pandemic. You want to consider a testing protocol? Let's make one. Why are you making all of these individual school boards come up with one? School boards aren't trained on how to contact trace.
Your Honor,
They're not trained on how to do any of this.
Excuse me, Dr. Nielsen. Excuse me, Dr. Nielsen. Yes, Mr. Wells.
at some time, can we have a question and answer as opposed to the long soliloquy?
Well, I think the question invited a narrative, so I'll allow Dr. Nielsen to continue there.
Thank you, Judge. And on page 67, if surfaces are dirty, use soap and water prior to disinfecting them. You don't say if they're dirty, you have to assume they're dirty. It's not an if, it just is. So in my opinion, there was a lot of lack of direction, lack of certainty, lack of definition, and lack of guidance. These are schools, these aren't hospitals. These are teachers, these are custodians, these are cafeteria workers. Don't make them create it. Tell them, wear a mask. We're gonna test, we're gonna contact trace. We're gonna provide your kids and your employees with a safe environment. There's some really inspiring speech in that PowerPoint, which is amazing. But then when you get to the meat of it, you get the bun, but you don't get the burger. I like the burger.
Dr. Nielsen, let's contrast that PowerPoint presentation with what's come out more recently from the CDC and the American Association of Pediatrics. What is the difference between what the governor and his task force put out regarding opening schools, which I believe may have dated all the way back to May, as to what's come out in the last couple of weeks?
In the last couple of weeks, the American Academy of Pediatrics, the president, he sent 5, potentially 6 copies of the exact same letter to the governor, stating that current states in the state of Florida, no school has any business opening. The sad part is that the governor has yet to respond to him, not once. Not even a secretary has responded to him. That's just not what I would consider appropriate. You've got the head of the Florida AAP saying, hey, you don't need to be open in schools. At least call him and say, why? Why do you feel that way? Let's talk. Let's work together as a team, because yes, kids need to be in school, but they have to be there safely. Then if you look at the CDC also is saying that in context, you need to look at your positivity rate, along with the World Health Organization. Your positivity rate needs to be less than 5% to effectively open, and you have to provide a safe environment. You have to have masks. You have to have science based on robust testing, contact tracing, and the ability to isolate and quarantine. Unfortunately, we don't have robust testing available in Orange County anywhere for children, not even in the outpatient setting. Dr. Pino mentioned that he has about 10,000 tests available for our students in Orange County. We have over 210,000 kids in Orange County. We're missing quite a few of those tests, I believe, if you will need to give every kid a test.
Dr. Nielsen, let's talk about a couple of things you hit on, which was positivity rate, masks, and testing. Let's start with testing. In your experience with the patients you've treated with COVID, how quickly are tests being turned around?
It depends on where you get the test. There's different tests out there. First, let's start with antibody testing. Initially, when this came out, everybody thought, oh, if you've got antibodies, kind of like you get from a vaccine, you won't be able to get it. That's now been debunked. And so we know that those tests are not really worth anything. You only have antibodies for anywhere from 30 to 60 days, and then they're gone. And not everybody creates antibodies. In my own staff, of the ones who got sick, half had antibodies, half didn't. So antibody tests have no place and no role in testing at this point. They're just not accurate or useful. Then you have to look at an antigen test. Antigen tests are usually rapid tests that can be run in a doctor's office. That's similar to your standard flu or strep test that you get when your doctor swabs you. There are primarily 2 manufacturers of the rapid test. One is Quidel, which uses the Sophia 2 machine. The Sophia 2 machine's also been used in primary care offices for things like flu and strep. So if you were lucky enough to already have the machine, which I believe there were about 1,000 in the country, so into the entire United States, then you could order the test and you can run the test. There is one local urgent care center here in Orange County that has that test. There is one pediatric office that has that test. That is the only 2 providers in Orange County, other than hospital emergency rooms, who has that test available for children. If you're 18 and over, you can get that test done at local Advent healthcare options and some other urgent care options, but not if you're under 18. If you go to the state's health department testing sites, they're not going to test a kid under the age of 18 unless they're severely symptomatic. And even then, my patients have gotten pushback. That's not with a rapid test either. That's with a PCR send-out test that can take 7 to 14 days if it's processed correctly. By the time a test comes back 7 to 14 days, you've increased your local spread and you've made the situation worse. So it's not a great test. Granted, the antigen isn't either. There's pros and cons to every test. But to be a good, effective test, you have to get an accurate result quickly. You don't find out for 14 days that you have it, well, you've already gone to Sam's and Publix and BJ's and, McDonald's.
And what does the CDC recommend as far as test turnaround time?
CDC says you need to get it within 24 hours, 48 at the most.
And you were on, like we mentioned earlier, you were on the medical advisory panel for Orange County Public Schools. Was there any discussion about maybe having Orange County Public Schools, Department of Education, or even the health department provide testing directly to students in the school? Or are they going to have to travel somewhere to get tested?
I asked that question directly, and Dr. Pino looked kind of surprised. He was not sure that there was anything set up. He had no location for kids or staff to go to. He simply said that he had 10,000 tests assigned to Orange County, but at that point, he had no idea what he was going to do with them, how they were going to be administered, who would administer them, or what the results would be done with. However, the CDC and the white paper from the American Academy of Pediatrics recommends having every parent sign a FERPA form, which is the Educational Protection Act. It's Trump's HIPAA, actually. HIPAA doesn't apply to any elementary or middle schools. FERPA does. And so the white paper, as well as the CDC, suggests having every family sign a FERPA. That way a test could be done at a school, and then you could get a result. So you would know how to appropriately handle that child, that classroom, and anyone exposed.
But in your experience, that hasn't been set up yet by Orange County Public Schools?
It is not at all.
Okay. Let's talk a little bit about, have you noticed from your research and some of the stuff that you've referenced and that we've put into evidence, an increase from July until August in the pediatric COVID rates?
Yes, definitely. My office currently has a 30% positivity rate.
Okay. And then let's talk about the positivity rate. That lends us right into a good conversation about that. Have you been reviewing the daily stats from the Florida Department of Health as to positive tests, number of tests done, number of negatives, and the actual positivity rate? Have you reviewed that?
I've reviewed it at length.
Okay. Can you tell me about, obviously we've seen the numbers dropping as far as positivity rate and positive tests. Can you tell me what that means after you've reviewed the raw data?
So my sister is a professor, a math professor in the University of Colorado at Boulder. So not only have I reviewed it, I actually reviewed it with her because it seemed so unbelievable and laughable to me. I wanted to make sure I wasn't overlooking something. So in reviewing it with her, it became pretty obvious we're double counting our negatives. So if you have to have 2 negative tests to return to work, both of those negatives get put into the negative denominator or the negative pile. Well, that dilutes your positivity rate. You can't double count your negative tests. And so we've seen the number in the state of Florida go very high, and it still has yet to be below 5% or anywhere near 5%. Today, it's actually 15.1%.
And how did you come to that number? Because obviously the Florida Department of Health has a different number on their website.
If you actually look at the data that they provide, so they actually have like a 2-sheet spread, so not just their dashboard. If you actually go to that, you can actually calculate your true positives and your true negatives, and it takes out the double negatives. And at the bottom of the second page, it actually has a little disclaimer that says the negative rate and this positivity rate are based on double negatives, that they're not correct.
Then let's talk also about, as it relates to testing, is there any indication that we're pulling out, and I don't know this, and you may or may not know it, is there any indication that, let's say for the NBA bubble down at Disney, they're testing, I don't know if it's every day or every other day, but they're testing a lot over there. And obviously they've done a great job in the bubble and they haven't had any positive cases as of late, is my understanding. Do you know if that data is being pulled out separately because that's not representative of the community? Or is that being
pulled out? It's not being pulled out. It's part of it as well.
Okay.
Same with Major League Soccer that was here too.
And all those numbers, do you think those are affecting our positivity rate, not only in Orange County, but around the state?
Yes, and Dr. Pino actually made a statement I saw in the news that said that you should assume that the positivity rate is considerably higher than what we're actually saying out loud.
Okay. And we talked about this 5%, or at least you mentioned it. It seems to be the gold standard. We've heard it from just about everybody that's testified today and in the news. Why 5%, Dr. Nielsen?
If you have 5% or less, then you're at less risk of creating more increased spread. So the goal when you have a pandemic is to control it. Don't let it get out of control. Don't let that fire ravage your entire county or state. So if you less than 5% or 5%, then you don't have numbers that will ravage it. And using things like hand washing, gowns, gloves, masks, social distancing will be effective. However, it's been shown and well documented that if that number is over 5%, masks and social distancing alone are not as effective because of the way it spreads, airborne and droplet.
Are you saying that we should keep schools closed until we have a vaccine? Or are you just saying, look, we need to keep schools closed until we hit, 5% or below?
I don't think you need to keep schools closed until you hit a vaccine, because just like with polio and smallpox, that can be a long way off. But what you do have to have is a situation based on science, robust testing, contact tracing, and the ability to keep kids safe. Because you can't bring those teachers and those kids in and say, hi, welcome back to first grade. Sorry, now you're going to go home for 14 days because Jimmy got it. And his sibling does too. So kids do need to be in school. That is so true. That's where we all know they need to be. However, you have to do it in the lens of safety. Otherwise, you're just going to spread it around and our numbers are going to go up even more. And then Jimmy's going to give it to his grandmother who might die. And then we've got to deal with Jimmy and his emotional needs for the rest of his life.
How do we do that? I mean, how would you recommend trying to bring students back to school safely? Would that include a firm date? By X date, we need to open all schools?
No. Kids whose fathers are firefighters don't expect Christmas to always be on the 25th. Santa sometimes comes on the 26th or the 28th, depending on his shift, last time I checked. Same thing is true with school. You can't say, here's my line in the sand, date I'm going to open. Because what if half of New York or half of some other state comes down to go to Disney World this weekend and it outbreaks again? Well, okay, let's be real. Let's keep Florida safe. Let's make sure we have air conditioning vents and ductwork in place that can protect kids because it is airborne, as well as teachers and industry staff. Let's make sure we have contact tracing in place. Dr. Pino mentioned at our last MAC meeting, he was hoping to hire about 130 people. That's a great hope. He hasn't done it yet, unfortunately. Let's make sure we have testing. He's got 10,000 tests for 212,000 kids and no place to do it and no one to do it. And he doesn't have the parental permission to actually do the test and no one to trace it. So that's a failure also. We're simply not ready. We don't have the things in place to open. We do need to open. However, you shouldn't do something so like that so flippantly and haphazardly.
And let's go into a little bit into the details, okay? There are certain things that are, we had a witness who came on earlier who's a teacher in Orange County, and he talked about concerns regarding bathrooms and changing classes and things like that. Are those concerns that were brought up to you as a part of the medical advisory committee, or are those things that were discussed, or do you think generally those things need to be a part of the reopen plan?
Those have to be part of the reopen plan. The American Academy of Pediatrics put that in their white paper. Okay, I don't know about you guys, but in a girl's bathroom, when you walk in, there's still no lid to put down on top of the toilet when you flush. Well, it's spread in the poop, y'all. So if you flush the toilet after you poop or you pee, it's going to go into the air. Now, no one else needs to walk into that bathroom for 30 minutes. Doesn't that make Target fun? So we have to think about kids going to the bathroom. Kids are messy. They pee everywhere. Most parents have noticed that about their own kids, let's be honest. So you also can't have more than one kid in a teeny tiny bathroom. So bathroom breaks are going to be laborious. Kids don't always use soap. There's not always soap available. There's not always paper towels available. So we have to think about how you're going to line up kids to go to the bathroom. Then you also have to consider water fountains and water refreshment stations. Those are expensive. Kids spit in water fountains. It happens even in my own office. It's nasty. I don't use the water fountain here. We have a certain water cooler for the staff. So you have to have these things in place because those are great surfaces to spread it on. And you would have to wipe it down between every single kid if you were going to expect to use those facilities. But no, the MAC has not been brought, that hasn't been discussed yet.
Okay. Are those things that should be a part of a discussion before we open up a school?
Definitely.
Okay.
Definitely.
And I looked.
And what the CDC initially said back in May was that every school bathroom toilet actually needed to have a lid modified onto it so you could close the lid before you flushed.
Has that been a part of any of the discussions at Orange County Public Schools? Or have you heard anything come down from the Department of Education or Department of Health about getting those installed?
Not at all. Not at all.
I also noted in some of the materials that I believe you reviewed and as part of our evidence about cohorting. It seems to be mentioned a lot between CDC and I believe even the white paper you've been referencing. Can you talk to us a little bit about what cohorting means and if that would be something you would recommend be implemented as a part of a reopen plan at some point in the future?
Cohorting is a great idea, concept, and reality. It's what we actually saw used in a lot of the Florida daycares this summer that were taking care of the kids of the first responders and medical community. What they did is they found one teacher, possibly two, to split the day with. They would take 5, no more than 7 kids in the same room at the same time, and they kept them together all day long. They didn't go play with any other children, so they kept their germs to themselves. Some of those kids even weren't required to wear a mask because they knew they were sharing their same germs with the same people. The families had signed contracts with the daycare facilities saying, we're going to be sure that we're safe. And if anybody gets exposed, we're going to keep our kid out for 14 days or until 2 negative tests. That actually happened to one of my coworkers because she was exposed here. Although she did not turn positive on her test or have COVID despite exposure, she had to take her child out and keep that child at home for a prolonged period of time until we knew it was negative, because it was the responsibility of the cohort. So if you look at elementary schools, that would mean taking 5 to 8 kids in a grade and saying, we're going to keep these kids together. They're going to move fluidly together. They're not going to play on the playground with this other class because then they share germs. We're not going to send them to the cafeteria because that's where they're going to spread germs. Instead, let's get some tents and put a tent out back so they can go sit outside and eat lunch. But let's keep those kids together. That's something that should be considered for middle and high schools as well, as opposed to all the changing of classes. If you have hectic changing of classes, you're going to have big numbers of kids in hallways. And I don't know about you, but our high school hallways weren't that big in Birmingham. And so we were always bumping into each other. So you have to consider changing classes, changing spaces. The less movement you have, the better you are.
Is that any of those recommendations you just mentioned about cohorting, modifying how middle and high school students change class? Has any of that been a part of any recommendations from the Department of Education or the Department or Orange County Public Schools?
No, it was brought up, I believe, at a board meeting. It was thought about. However, it was said that that was going to be unrealistic and not possible to obtain or achieve.
Okay. And in your review of the what's marked as, I believe it's Plaintiff's Exhibit 36, which is the reopening plan we talked about earlier, Dr. Nielsen, from the Department of Education. Did you see anything about how to implement these, the cohorting or modifying, changing schedule, or even as simple as putting seats on toilets that you mentioned earlier?
Not at all.
Okay. The governor's talked, as well as the Department of Education, have talked a lot about concerns with children falling behind, which is obviously a huge concern for a lot of people with what we're going through. In rendering your opinions about whether it's safe to return to school, have you taken that into consideration?
Definitely. And my staff and I have actually brainstormed on some ways to work with that, because yes, kids need to have education, but if a kid is dead, they're not going to need education anymore, I think. And so what we've said is that, you know what, let's look at these kids. Let's talk to the local Boys and Girls Club. Let's talk to churches. Let's come up with ways to make learning pods outside of the school environment for these kids. One of my best friends is the CEO of the Hope Center in Osceola County. They serve the underserved along the 192 route and countless numbers of kids and families living in homeless shelters as well as hotels. She did an informal survey for me because I was curious and I wanted to know how I could represent those kids the best. And so I asked her, I said, find out how many of your patients, your kids, those parents want their kids to go back to school. My favorite response to one of her questions was, hell no, I'm not sending my kid. None of them were going to send their kids back. So I think we have to take into consideration even the people who may be indigent, who may not be affluent, who may not even be middle class. They don't feel it's safe to go back to school. And so we need to be serving all of our customers and all of our clients and all of our students and families. So we have to figure out how to get boys and girls clubs, churches, neighborhood road captains together to work with those kids.
Do you believe that there is a way to, the word I'm going to use is very basic, but partially open schools to some people who are in those more at-risk categories rather than having everything must be open order effective August 31st? Do you think that's a possible recommendation that you would agree with? And would you believe that would be safer?
I think it would be a much more humane option, yes. Because the other thing that we know from the CDC is that those medically more complex kiddos, those special ed sensory kiddos, the kids with higher IEP levels and services are actually more vulnerable for COVID and for complications, as are our obese kids, our diabetic kids, our asthmatic kids. And so you have to take that in consideration as well when you're talking about opening. But a full-on opening is totally irresponsible.
Perfect. Doctor, I skipped a couple questions at the beginning, so I'm going to go back and then we'll wrap up with a couple, but you're almost done. I appreciate your testimony here today. And my understanding, and you can correct me if I'm wrong here, doctor, this is the first time you've ever been asked to testify as an expert in your field?
Correct.
Okay. And you haven't been retained by either of the plaintiffs, correct?
No.
You've just been asked to testify, not obviously been paid by anybody.
No.
Okay. Dr. Nielsen, just to wrap up, just generally, Dr. Nielsen, what is your recommendation as it stands today? Do you think we should be opening schools by August 31st in the state of Florida?
We have no business opening schools based on a certain deadline, and definitely not by August the 31st. If you look at Orange County specifically, right now they have MERV 10 filters in their HVAC systems, and they are very proud of that fact. Unfortunately, MERV 10 AC filters don't filter out COVID. MERV 13 does. And so we don't even have appropriate air filters in schools. I understand that Orange County systems are not meant for a MERV 13, but that means we need to get individual air filtration options into each one of those classrooms. We need a chance to talk with our foundations in the schools. We need Home Depot, Pine Castle Hardware, Miller's in Winter Park. We need all of our local hardware places and Lowe's to jump on the bandwagon along with ACE and get us some air filters in these schools across the state. Because if you're going to open up, you have to have the air clean. You have to have the ability to be safe. We're not there. We don't have anything ready. It's like a disaster waiting to happen.
If schools open, what do you think is going to happen, number one, and what is the protocol from your time on the medical advisory panel? What is going to happen if somebody does come down with COVID in a school?
Well, somebody's going to show up the first day with it. Let's just be honest. You can know that based on what happened in Seminole County. You don't have to recreate history just to figure that one out. So the first day, someone's going to have it. Someone's going to be exposed. And unfortunately, we have yet to be presented with the plan for what's going to happen if someone does get it. That's part of tonight's MAC as well. So we don't know what Orange County's plan is. I know what Oregon's Department of Health's plan is, and it's phenomenal.
Okay. And we can talk about that in a second, but let me just go back real quick. It's my understanding that, my daughter is going to school virtually this year and is in kindergarten here in Orange County. Are you testifying here today that as it stands today, if somebody shows up with COVID on Friday when brick and mortar schools open, there's not a specific plan in place on how to handle that?
There's not a plan that MAC has been shown or approved of. As of the Monday night school board meeting, the school board members themselves were also unaware of what the plan was.
Do you know if we're going to require a negative test before students come back to school?
I don't believe that's on the table at all.
Let me rephrase that question. Are we going to require a negative test before they come back to school if they've tested positive for COVID or been potentially exposed to COVID?
No.
Okay. Dr. Nielsen, let me just look through my notes real quick. I think I may be wrapping up with you. Judge, if you'll just give me 1 second.
Sure, yes, sir.
Thank you. Dr. Nielsen, you may have covered this, but in your research and your experience, is COVID-19 passed both through the air as well as on surfaces?
Yes, it is. Yes, it is. So there actually was a study that came out in January, and it was referencing a restaurant in Guangzhou, China. And what happened was there was a family that was sitting on, and I believe I have a copy in the summer if you'll need it. There was a family that was sitting on one side of the restaurant at a round table. The air duct started at this side. Let me see if I can do this on camera. And then there were so the return was here and the output was here. So the family sitting over here where the return was healthy. There was one family member on the input of the air, so where air is being sucked up. There was one family member who was ill, not known to have COVID at that point. However, this family, 3 people ended up having it. Then this table way over here ended up getting it as well. It was on the third, I believe it was on the 5th floor, the 3rd floor of a 5-floor restaurant that happened at. And that 3rd floor had its own individual air conditioning system developed for it. And so it was shown to be airborne at that point. The sad thing is that when you get a new virus or a new plague or a new whatever, you don't know everything about it, just like when you get a new car. So you have to kind of play around with the buttons and see what happens. And, you know, I got a new used car back in January. Yesterday, I found a new feature. It was pretty cool. Illnesses are the same way. When you first get an illness, we thought it was just droplets, but then that showed it was airborne. But then we didn't have any ability to do any more research on it really since then. The University of Florida came out a week ago, I believe it was, with a paper where they showed it was airborne as well. So it's no longer droplet. You have to know that it's airborne as well.
And that's what you're referring to about the filters within, at least as far as you know, Orange County Public Schools doesn't have the proper filter to keep COVID-19 from traveling through their HVAC system.
Correct. That was what the head of the custodian department disclosed Monday night at the meeting. Also, if you think about it, if it weren't airborne, we'd all be sitting in the same room together right now, wouldn't we?
Doctor, one last question. I think we've kind of covered it, but I'd like you to just kind of reiterate, and then I'm going to move some stuff into evidence after you're done talking. But generally, what are the risks if we do go ahead and open schools by August 31st, or as far as Orange County is concerned on Friday?
Numbers are going to increase. You're going to have kids get sick. You're going to have teachers become sick. You're going to have everyone in the school will have a close contact who becomes sick. So not only will you have illness, but then in response to that, you'll also have complications, whether that's heart issues, dialysis issues, multitude of issues that you can have, clotting issues, strokes, and then you're going to have the hospitals start to fill up. And that's when your elective surgeries get cut back. That's when your ICU beds get clogged up. We already don't have an appropriate ICU bed number to be opening up. I looked at it a little while ago, and right now in Orange County, let me get to this page. Sorry about that. In Orange
Doctor,
County,
are you pulling the numbers from today about the ICU beds from the
ACA, from the ACA one, because it's no longer being released accurately. However, Florida's doing better than the nation. So in Orange County, the available pediatric ICU beds, we have 42 beds in Orange County that are available out of 112 beds. So if you get 42 kids who need to be in an ICU bed, you're great. But what about that 43rd one? We don't have it. We know that 1 out of 3 kids admitted to the hospital, just like in an adult world, end up in the intensive care unit. There are 234 people in-house in hospitals in Orange County with COVID. There's only 81 adult ICU beds available right now, also in Orange County, out of 291. That's not very many. I want all my teachers to have an ICU bed if they need one, but I don't want them to go there anyway.
Last question, Dr. Nielsen. I thought I probably said that about the last question, but this truly is going to be my last question. The fence has painted a picture sometimes of gloom and doom and nobody wants to open schools. That's not your testimony here today, is it?
Not at all. I want kids in school, but I want them to be there, and I don't want them to have to keep coming out. I don't want a kid to go for 1 day, get sent home for 14 days, go back for 2 days, home for 14 more days. When you could just go a little slower, be a little bit more diligent, be ready. Now, granted, you could have started getting ready a lot earlier than this, but we could have been getting ready. And that way when kids go, they can stay. It's not good for anyone's mental health. That yo-yo effect is what's going to cause more issues with the way kids are feeling. They're going to be, hi, there's my teacher. No, it's not. Hi, there's my friend. No, there's not. That yo-yo effect is worse than the existence right now, according to my current teachers and my patients.
Thank you, Doctor. Judge, we'd like to move some things into evidence based on her testimony and things that she's relied upon as an expert. Those items, Judge, would be plaintiff's exhibit numbers 8, 13, 27, 36, 49, 50, 51, 53, 54, 59. In addition to those items, Judge, I believe Dr. Nielsen pulled some additional information that was not available before today because it's based on today's stats. And those would be the ACA numbers that she referenced here at the end of her testimony, as well as I believe what we refer to as the Department of Health's daily COVID report with the numbers that are provided. Judge, those are the items that I believe Dr. Nielsen has relied upon in her testimony, in addition to her curriculum vitae, which was provided to defense counsel as number 49. But every other item that I've referenced, I believe, is something that Dr. Nielsen relied upon or reviewed as a part of her testimony as an expert here today.
Your Honor, I apologize, but it went way too fast for me to get all the numbers. If you could.
I'd be happy to. You want to take them one at a time, Dave?
Yeah, thanks.
Sure. Number 8.
Okay.
Which is the white paper Dr. Nielsen referred to.
I've got your list now so I can read
Okay,
it.
good. Number 13.
Okay.
Number 27. Number 36, which is actually y'all's one of your pieces of evidence as well. Number 49.
Hang on.
You're fine. Number 49, which is just your CV.
I got that. 49.
Number 50.
My list stopped at 49. What's 50?
50 is the Florida, and Dr. Nielsen can help me with this. It's the Academy of Pediatrics for Florida. What's FC stand for?
The Florida chapter.
Florida
the Florida
chapter.
chapter of the American Academy of Pediatrics.
And that's
Okay.
the consideration for school reopening. 51 would also be another one that's similar to that, which is the white paper Dr. Nielsen referred to.
Okay.
53 would be the article that she referenced about, I guess technically it's a study that was referenced from China about the virus being airborne. It's obviously not a Chinese study, it's a CDC study. I think that goes without saying. Number 54, which is an article titled Preparing K through 12 Administrators for a Safe Return to School in Fall. And that's from the CDC. And if one of my colleagues can help me with number 59, I have the old list. I don't have 59.
That's also another CDC article.
Perfect. Dave, do you have any questions about any of those?
No, that's fine. We don't have any objection.
No objection, you say, Mr. Wells?
Yes, Your Honor, I'm sorry.
Okay, so plaintiffs 8, 13, 27, 36, 49, 50, 51, 53, 54, and 59 are admitted.
Dr. Nielsen, thank you. I think Mr. Wells may have some questions for you.
Thank you.
Your Honor, can we take a short break before we do our cross? We've been going.
Let's take a 5-minute break and we'll start with the cross.
Thank you, Your Honor.
Dr. Nielsen. Court will be
Dr.
recessed.
Nielsen, if you want to use the bathroom, you can obviously mute it or turn off your video or both.
Cool. Thank you.
You're welcome.
Okay, Mr. Wells, you may start with the cross-examination of Dr. Nielsen.
Thank you, Your Honor, and I'll be brief. Dr. Nielsen, you have an active pediatric practice, don't you?
Very.
You've gone from 0 to 6,000 patients. That's amazing. As I read your resume, your fellowship was in hematology and oncology?
Yes, pediatric cancer and blood disorders.
Right, and that was after that was your fellowship. That was after a residency at Arnold Palmer Hospital in pediatrics.
Correct.
You didn't do a residency in infectious disease or in epidemiology, did you?
Part of pediatric hematology oncology is unfortunately infectious disease, because if a kid doesn't get another diagnosis, they end up with us, and we often end up finding the infectious disease. It was not a straight up fellowship, no.
Well, I mean, let's be clear. Your residency was in pediatrics, right?
Correct. General pediatrics, which includes infectious disease as well as epidemiology.
And there are people who take residencies in epidemiology.
Not in residencies. They take fellowships and they take master's degrees, but it's not a part of a medical school degree.
Fair enough. So, but you don't have a fellowship in either infectious disease or in epidemiology.
Correct. Not a fellowship.
Okay. And you talked about research that you have done with respect to coronavirus. That's something you do as being a pediatrician to keep up with what's going on and what's affecting children.
Correct. A lifelong learner in medicine is important.
Understand. But you're not a researcher in the sense of someone who has done research it and published it to be reviewed by other doctors or other research professionals.
I actually am. So back before I went to medical school, I did asthma drug studies as part of the AstraZeneca and multiple asthma drug studies. So I've been a medical researcher as well.
Okay, well, let me just be more focused. You haven't done any type of published research on the concept of coronavirus and how we should address it.
Correct.
Nothing's been published, nothing's been reviewed on your opinions on how to address it.
Correct.
Your views are based on your experience as a pediatrician and what you've read.
My views are based on fact from the American Academy of Pediatrics, the CDC, and other services like that. Yes.
That you've read. You've sat down and read it.
I've studied, and I've talked to other epidemiologists and asked questions too. Correct.
Fair enough. And so in terms of anybody being able to evaluate your opinions, there's nothing that's been published out there, nothing where any other researchers or doctors have commented on it.
I think by the pure fact of being invited to the medical advisory committee, I'm a pretty well-respected pediatrician in town.
Okay, thank you. We don't have any other questions.
Any redirect?
Just quickly, Your Honor, Dr. Nielsen, coronavirus started when?
We had 38 cases in Orange County on March the 13th.
Other than the CDC and maybe a couple other larger agencies, have you seen much in the way of published studies as far as COVID-19 is concerned?
There is nothing. In fact, my office is in the current process of filing a research paper on children having an increased risk of type 1 diabetes with COVID. We've had 3 new type 1 diabetic patients in the last 3 months. So it's been shown, at least we perceive it's been shown, that type 1 diabetes is more prevalent to become an new onset illness in the light of the COVID pandemic.
And let's just sum up your testimony generally, Dr. Nielsen. You're testifying from the perspective.
A bit beyond redirect here on my limited questioning to sum up her testimony.
Sustained.
Your Honor, may I be heard just briefly?
Sure.
The only question I was going to ask her, Your Honor, was just simply based on Mr. Wells's assertion that essentially she's not an expert in her field. I was just going to simply ask her that her testimony was simply based upon her experience as a pediatric doctor and her research and review.
I'll allow you to ask that one question.
Dr. Nielsen, do you need me to repeat that question or you got it?
No, I would agree with you. That's exactly correct.
Okay. I don't have any further questions.
Okay, may Dr. Nielsen be excused?
Sure.
As far as the plaintiffs are concerned, Dr. Nielsen, thank you for your time. Thank you, Judge.
Dr. Nielsen, you are free to leave the meeting. Thank you very much.
Thank you so much.
I'll call you next
Your
witness.
Honor. Have a great day.
Thank you too.
Your Honor, our next witness is Dr. Thomas Burke, and Jacob Stewart will be conducting his direct examination.
Okay, I'll let Dr. Burke in. Dr. Burke, are you there? There you go. There you are. Dr. Burke, if you'd raise your, unmute yourself there and raise your right hand, please. You swear the testimony you give today will be the truth, the whole truth, and nothing but the truth.
I do, Your Honor.
Thank you, sir. You can put your hand down.
May I proceed, Your Honor?
Yes, sir.
Dr. Burke, it's finally nice to see your face when you're talking on the phone, so it's good to see you. A few things, sir. First, I need you, there's a stenographer recording what's going on, so I need you to say and spell your first and last name, please.
Okay. I'm Thomas Burke, and that's THOMAS and BURKE.
Thank you, Dr. Burke. And we're going to have to go through some of your background before we get into testimony, okay? The first is, tell us a little bit about your professional degree, starting with undergrad, if you could.
Okay, I have a degree in mathematics and a degree in neuroscience from University of Massachusetts in Amherst, Massachusetts, and then a doctorate in medicine from Albany Medical College. And then I thereafter was at a joint program at Madigan Army Medical Center, as well as at the University of Washington in a 4-year program in emergency medicine.
And then after your residency, my understanding is you ended up serving our country in a capacity with the military. Is that correct?
Yes, I was in the United States Army for 7.5 years.
And were you on active duty at any point in time, or were you in reserve?
I was on active duty the entire time.
And what was your capacity while you were in active duty as a doctor?
I was a faculty emergency physician at Madigan Army Medical Center. And again, that was a joint program at that time with the University of Washington. But then I additionally was deployed to a variety of military engagements.
And then at some point in time as well, you were working with the FBI, the Federal Bureau of Investigation as well, here back stateside. Is that correct?
Yes, I was the doctor at, for those that are more my generation or older, I was the doctor for the FBI hostage rescue team in Waco, Texas, and then also in Ruby Ridge, Idaho.
And you also were in Libya back in September of 2012. Is that correct? When there was the attack on our embassy there?
Yes, I was.
All right. Well, thank you for your service. I've communicated that to you, but I want to do that again. After you were done serving our country in those capacities, did you end up moving to a different station in your life where you are currently?
Yes, I worked in community medicine for a number of years. And then in 2004, I was invited to become faculty at Harvard University. And I've been a practicing physician at the Brigham and Women's Hospital, Boston Children's Hospital, and the Massachusetts General Hospital over that time since 2004.
And so, you know, your curriculum vitae is, it's very impressive. It's like almost like a book, Dr. Burke. So there's so many things to go into, but, you know, in relation to the study of pandemics and infectious diseases, would you mind reviewing some of your work you've done in that capacity?
Yeah, I think I would start by saying that my non-clinical work is I'm a senior faculty at the Harvard School of Public Health in the Department of Global Health and Population, and then also at Harvard Medical School. And I was the founding director of the Massachusetts General Hospital Center for Global Health. And then I'm currently the director of the Global Health Innovation Lab at the Massachusetts General Hospital. And all that work, and actually, really a considerable amount of my work in the last few decades has been focused on population health, and my focus is on women and children's health on a variety of different in a variety of different areas, but essentially on survival and mortality. When it comes to activities currently that I'm involved in from the COVID-19 perspective, I've been asked to provide consulting services, and none of these I get what I do. And I've been a consultant to the Bahamas government, to Barbados, St. Lucia, to the Kenya Ministry of Health, Tanzania Ministry of Health, and the India Ministry of Health on COVID-19 pandemic. And I've chaired several webinars, 5 webinars to various ministries of health that invited their nation's doctors to be participants and listen in on providing guidance and advice. I also am a consultant for some very high-end travel by private jet companies that actually brings in revenue that goes to poor people. I never touch it. It's a bit of a Robin Hood approach, but on how to address their own businesses during COVID-19 and how to develop green light protocols ultimately to reopen their businesses.
And in all this work, you're also, my understanding is on a committee at Harvard University in regards to domestic violence and COVID-19 as well.
Yes, I'm a board member of COVID-19 task force on domestic violence, and similarly one for the International Federation of OBGYN. I was just asked to be co-chair of a task force on COVID-19.
And so is it fair to say, and this is again for the record, I'm not trying to question your credentials, but as part of your position or positions, whether it's volunteer or working officially with Harvard and Massachusetts General Hospital, that you keep up to date with current research that's ongoing with the COVID-19 pandemic?
Absolutely, that's true.
And it would be fair to say that since the pandemic became known to Americans, whether it's October or January or anywhere in between in terms of which portion of the population became aware of it, would it be fair to say that this is a evolving type situation where we're learning more about the virus on a daily basis?
Absolutely. In fact, one of the joys of being a faculty at Harvard Medical School, we get updates on the COVID-19 research a few times every single day. I mean, literally 5 to 7 days a week, we'll get updates on data that's coming in, new understandings as it's evolving.
So to be clear, you're even though you're not here in Florida, you're aware of the pandemic and its effect of the COVID-19 pandemic specifically here in Florida and what's been going on in Florida.
I certainly am, and I have 3 grandchildren in Florida, so I'm especially paying attention to Florida.
I understand that. And going back, you're paying attention to Florida. You've been looking at daily statistics in regards to infection rates and what's been going on. Is that fair to say?
Yes, that's true.
All right. So starting off, as part of your studies, before getting to what's going on in Florida, have there been other countries already that have begun to look at opening schools, like meaning brick and mortar physical schools?
It's a great question, actually. So I think, something that we all could certainly learn from is looking across the ocean at other countries and how they've approached the pandemic. There are a number of different experiments that have been tried as to how to address the pandemic and then how to reopen schools. And we see Austria, Sweden, the Netherlands, Germany have been able to successfully reopen schools, whereas in Israel, they had significant trouble. And what did we learn from that? We learned that in countries where they drove down the community spread and then had mitigation factors in place in schools, which in some countries included bubbles, essentially cohorting students or having alternate days and ensuring that the student didn't aggregate and that they had cleaning materials available and PPE available, certainly for.
And Dr. Burke, not to interrupt you, but you obviously are familiar with some of these terms. I want to make sure we are, because I don't know all of them. When you're looking at a study like we're talking about, you mentioned these different standards. And so what I guess I'm looking for is that specifically when you're in your line of work, when countries or communities will participate in pandemics, is it traditional that those practices are then reported to some type of database or something that's shared with professors and doctors like you around the world? Absolutely.
There's actually quite a bit of literature there's many journals have, in fact, turned their entire attention to COVID-19. So there is peer-reviewed literature emerging, quite frequently, and and in pediatrics, in MMWR and in the CDC weekly reports, we're seeing data emerging that helps us make decisions, and the data that is verified and validated from Europe is particularly helpful because their school calendars are different than ours. So they've had an experiment for us to, many of the countries have had an experiment for us to learn from.
So going back to that, and forgive me for going out of order, but that context you provided is helpful. Going back to the two examples you cited before we get to what's happened in Asia, but specifically in the Netherlands and Germany versus happening in Israel, tell us what's from your medical profession, what's worked and what hasn't worked, and opening it up in specifically in-person schools.
Right. First of all, ensuring that community spread is down, at least 2 weeks of a downward trend, and then certainly less than 5% positive rate. That's clear. That's become fairly standard. And then secondly, those countries that have been successful have had significant additional investments. One, just moving to a virtual training platform for teachers and for a school is not trivial. To have quality education across virtual is expensive, but then moving that then back to in person requires investing in the school in terms of ensuring that hand sanitizer is available, ensuring that there is protection, as students between classes, ensuring the classrooms are safe and cleaned properly. And then you have to have contact tracing, and you have to be able to, otherwise the schools are going to shut down very quickly. And that's what happened in Israel. There wasn't contact tracing in place, and they also made they lifted children and the staff needing to wear masks. And as soon as that happened, the rates exploded, and the schools had to shut down.
So there's a couple things there you said I want to focus in on. When you say community spread, what exactly do you mean by that term?
Yeah, meaning that the disease prevalence, in other words, the presence of the disease within the community, is being spread from person to person in such a rate that the disease is actually expanding. We need the disease to not expand, and we need to actually get it to shrink. And so once it's spreading within the community, we really have to be stringent in mitigation efforts in order to get it under control.
So before asking you about any examples you have from Asia, is it from what you and I have talked about and some of the literature that's already been introduced evidence, does there have to be a plan before you can start talking about the conditions of the community and also the mitigation effects? I mean, is that the first step? How does that work if in school is to start?
Yeah, well, certainly, again, teachers, staff at school do what they do. They're committed, but they're not public health officials. They're not doctors. They're not epidemiologists. They need help. We need to work together, put our heads all together. So there needs to be an overarching guidance within certainly the flexibility, with the flexibility for local determination based on, the assets the local community has in place, and the community spread in a particular community, and the ability for a school to provide mitigation effects, including contact tracing.
So before we talk about Florida, are there any other lessons that you have learned in terms of your perspective of how COVID-19 affects children and teachers and learning of in-person from Asia?
From Asia.
Specifically South Korea?
South Korea. Well, I mean, there's more than, actually, since this study came out from South Korea, there's even more evidence that that actually children, particularly above age 10, have higher concentrations of virus than do adults, it appears. And this is hot off the press. It's actually in JAMA Pediatrics, Emerging Infectious Disease, and MMWR just in the last few weeks. And that children actually can and do spread the disease. And indeed, children, we still don't understand very well, have a higher resilience, but they can be the vectors and are the vectors. And we've seen that in there was a study published looking at camps in Florida, in fact, as well as other settings of daycare where children are able to rapidly be, convey and spread the disease.
So if a child gets COVID-19, meaning a person under 18 years of age, is it possible that even if they don't die, they could have long-term effects, meaning any issues with any of their major internal organs or neurological or anything of that nature?
I think that's an extremely important question, issue for children and all of us, because, currently those that are watching, which I think are most of us in this country now, we see positives that are confirmed, and we see mortality rates. And then we see some prevalence based on those. What we're not seeing is the true injury that is being caused to the American population. For every one that dies, there are many, and we don't know the answer yet, but I will tell you from population-based research that I do, these numbers are usually between 10 and 20 times when a mother doesn't die from a particular disease, which is a lot of my research. It's usually 20 times that number don't die but become injured. Children with pneumonia, which this now gets very close to, children with pneumonia worldwide, many, many die. Those that don't die, there are 10 times that number that are permanently injured. So when we look at what's happening to our children in the United States, we have to be mindful that there are children. I've had a child that didn't die, thankfully, 10 months old, but was critically ill, heart failure. That little girl is going to be in trouble for the rest of her life. And those are important numbers for us to pay attention to, but they're not being shared, publicly.
And talking about numbers, you mentioned before the positivity rate for a population. It's introduced into evidence already, but do you agree with the CDC, the American CDC, I should be specific, and their 5% positivity rate that's the gold standard, the rate of which it needs to be below before we start opening up things in person?
Absolutely, and that's a minimum standard. I mean, the Europeans have driven well below that, and been successful in opening schools. And so we definitely need to get to that point before we open schools. But certainly our targets are even better than that.
And coming back now to Florida, and talking about what this suit's about, which is whether or not in-person schools or in-person teaching in brick and mortar schools should open and how that should happen. We've had examples, you talking about different models. There have been professional sports, specifically in Central Florida, that have worked, National Basketball Association's doing that right now. So how is it possible, from your perspective, that the NBA can do it, the National Basketball Association, meaning having a large group of people together and having a relatively, I think it's less than 1% rate of positive infections. How can they do it, but not schools do it?
Yeah, it's a really great question. And there's a whole ethical principle in there that I find extremely troubling. And that, so professional sports in general, I just want to make a statement here. Professional sports in general, we are all so excited that they're beginning to, provide us entertainment. Yeah, but look at, players are allowed to opt out. And why are they allowed to opt out? And we all respect it because they might live at home with an elderly family member or someone who's vulnerable. And yet they're opting out and not playing because they know they would be at risk. However, what kind of risk are they at? They get tested almost daily, if not daily. The NBA and the NHL are in bubbles, and the NBA is right there in Orlando, of course. And so a tremendous amount of work for them to feel safe, to be able to do what they do, to play a sport, for us all to believe that they are safe, there need to be mitigation efforts in place. Their population and community is not 5%. It's well below 5%, if not zero, for them to feel safe. And they are not allowed outside of that bubble. They have every mitigation effort in play that that we all would love to see our children have access to as well. So what we say is a standard is necessary to keep the families of professional athletes healthy. We don't come anywhere close to for our children.
And what about the teachers as well at schools? I mean, they face the same type of issue as well as the children.
Absolutely, absolutely. Teachers are absolutely being placed at risk. Yes.
So going back now specifically to Florida and what this case is about opening brick and mortar schools, you know, is there any situation, let me put it this way for you as the expert, because clearly your credentials speak for themselves. If there are 60, are you aware that there are 67 counties in the state of Florida? Are you aware of that?
I am.
And you mentioned before, if any of those counties have a 5% or higher infection rate of COVID-19, is there any situation that you can find or that you believe that would be permissible to open up brick and mortar schools here?
No, we cannot open brick and mortar schools, in-person teaching with a community positive rate that's over 5%.
And why is that?
Because the risk for rapid expansion, for rapid surge of disease that'll harm the population as well as overwhelm the health system, gets magnified immensely.
And so let's presume though that, well, I just want to be clear. So your testimony is that there is no plan or no situation that you would deem safe for the students, teachers, or public if the infection rate is 5% or higher.
Absolutely.
All right. If the infection rate is lower than 5%, meaning we have a condition that you find there may be some type of plan or green light conditions that can be permitted. If you were to bring children back into a classroom, what are some of the things that would be necessary based upon your studies and your entire life's work that would allow there to be minimized or mitigated of the transmission of the virus, doctor?
Yeah. So we need to have a plan. We need to have a plan in place for what happens when someone is tested and is positive. How do we actually behave in order to keep the children safe? Because just because it's below 5%, if it's 4%, that still means that there's COVID virus out there. And we want to continue to stay below 5% and drive below 5%. So we need to have available, there needs to be mandatory mask wearing, not conditional, but mandatory mask wearing above the age of 2. There certainly needs to be the availability to have, children need to be mentored in washing their hands continually, keeping their masks on, and being able to, stay within either aggregated small groups that they're committed to, or actually be spaced at all times. There needs to be cleaning protocols for institutions, and the air quality needs to be ensured that it's safe and filtered. So there's a lot that needs to be done in order to maintain and ensure that that we have safety. And then there needs to be contact tracing. Otherwise, the schools would rapidly shut down, even if below 5%, because there'll be chaos. A few students test positive, and if there isn't a clear plan in place, there isn't contact tracing, then a wildfire will begin.
So to be clear, if there is below 5%, what would you, as a doctor who specializes in this type of area, what would you want the infection rate to be before you would recommend opening brick and mortar schools with the mitigation you've described?
Yeah. Once the community's spread is at such a level that it's been driven down, so the positive rate is 5% or less. And during that time, between now and that moment, or hopefully it's well underway, prepare the schools in a fashion that they can figure out ways, and each school is going to be a little bit different depending on their positivity rate, but depending on the architecture of the school itself, depending on the size of the population of the classroom. So starting slowly, seeing how it goes, introducing perhaps every other day. There are many different models, and there are lots of examples out there, but introducing in person in a way that makes sense, can be adopted, and we can grow, toward what we've, towards a full brick and mortar, but not start and stop immediately.
So is it fair to say that you would not recommend, as of Friday, that we open up brick and mortar schools in all 67 counties in the state of Florida?
Absolutely. That doesn't make any sense.
And what would be the result from your expert position if we did open up brick and mortar schools in all 67 counties Friday or next week? If that were to really begin to happen, what would you say that Florida should be able to anticipate in the coming weeks and months?
Yeah. In the last couple of days, with great hope to all of us, we've seen the numbers coming down a little bit in Florida. It's pretty exciting. We'd see an explosion in Florida if we reopen the schools the way that's been described, sudden opening of all schools.
And going back to what you said about mitigation for schools when they do open that are appropriate, you said that masks are absolutely mandatory. Everyone would have to wear a mask. Is that correct?
Absolutely.
You said that you would have to teach children proper hygiene and behavior for cleaning themselves in their desk area. Is that right?
Absolutely.
You would have to look at ventilation in each room in each of the schools. Is that correct?
Yes.
And then you mentioned before, as I have it here in my notes, as an absolute must, you mentioned you have to have contact tracing. You mentioned that a few times now. What is contact tracing and why is that so important in protecting the citizens of Florida and the country, like you've just described?
Yeah. Well, contact tracing is when someone tests positive, to be able to break the chain of transmission, prevent further transmission. And the way that needs to be done is whomever that child, in this example, whomever that child has been in contact with, then also is there's a boundary, a quarantine that's put around them so that they can understand if they are safe. And now you block the ability for that particular virus amongst that group that were in contact with one another to break out of that group and infect others. And hopefully then you've contained it within that group, even whether or not, if that one child becomes an isolated infected child, that's fine, that's great. But it's possible that those that person has been in contact with are also infected. So to break the chain of transmission, we need to test and contain.
And without masks, without proper hygiene, without contact tracing, is there any way that we could successfully open schools, even with a low infection rate, and continue to fight off the virus?
No, these work in absolute tandem. You can't open schools until you get below 5%, but you will quickly go back above 5% if we don't have mitigation strategies in place, as you just described.
I want to talk to you about there's a prevailing counter argument by others in your profession about this idea of herd immunity and why we should open schools, and something similar to the Sweden model that you mentioned before earlier, I believe. Tell us what this idea of herd immunity is in terms of dealing with the COVID-19 virus.
Yeah. Herd immunity means that we infect enough of the population that it really breaks the line of transmission, that enough people have gained immunity so that those remaining, and whatever that number is, 30%, it takes somewhere 55 to 70% of the society at least to have immunity in order to protect the rest. There's some real problems with that. One is the lethality and injury associated with this infection is really unacceptable. We can't just say that we're going to lose some astronomical number of Americans to death and disability. So that's one. And we know there's neurological injury, there's kidney injury, there's cardiac injury, there's pulmonary injury, and this includes children. The other is we don't know enough about this disease to know that that would even be effective. We don't know enough to know that herd immunity will even exist and prevail, that once one is infected, one is immune. We hope that's true. We do know that the immunizations that are being worked on are hopefully even going to be stronger in creating an immune response than if one was infected. But we don't know enough to know. It would be quite risky and speculative to imagine that we would all be safe if we killed off some big portion of our population so the rest of us are safe. That may not even be true.
Right. So even if we sacrifice a portion of the population on the herd immunity theory, due to our lack of knowledge of the virus, it may not work.
Absolutely.
We may have lost all those lives for nothing.
Absolutely.
What about this idea that children who are home doing virtual learning aren't getting the same learning or the same level of quality of education that they would in person? Is that an accurate statement?
I think what's accurate, to step back, is that all of us, I think everybody can come to consensus that we all want in-person learning, that in-person learning is ideal. The relationships with teachers, with staff, with the socialization that occurs is important in the growth and maturation of children. But at this time, when it's unsafe, that equation takes us to a place where we know the formula that's most widely agreed upon, which is this 5%, and then really having a strategy and set of mitigation efforts in place. So without that, we can't do it. But we do know virtual learning is in many ways inferior. There are a few students that have better learning with virtual, but the majority in person certainly is without question better.
And so in that same vein, there's also an argument about bringing children back to school and brick and mortar, in-person learning, due to the rise of domestic violence issues.
Yeah.
So I would ask you to speak to the court and to Judge Dotson about the balance, from your opinion, about the threat of children being victims of domestic violence versus what them being in school means to the pandemic, like you've talked about before.
Right. And I just recently authored a piece in Lancet Global Health in an editorial on this very topic. And that is one of many reasons why it's so important for us to get children back to school in person as soon as it is safe and as soon as we have plans in place. We know that in times of stress, domestic violence increases. And we know also that teachers and school ecosystems play a very important role in the safety of children. And there are actually several other countries have already put into place mechanisms in order to identify students that are at risk and to provide community services and check on students. In fact, my own daughter, who is a teacher in Florida in Seminole County, described that they have put together car caravans to visit students, particularly students at risk. They even put together birthday parties, not just virtually. They go to their homes in their cars and surround so there are community activities that we do need to put into place in this time of virtual world in order to keep children safe, not just from the virus, but keep children safe in other ways.
I want to go back to this, Dr. Burke, because I think it's important. The idea, though, we all can agree that any child or any person, woman or man, who's the subject of domestic violence is a horrible thing, correct? No one should have to endure that. But from your perspective and your unique role and your background, does the threat of a child being a victim of domestic violence, does that outweigh the current pandemic and what that could mean long-term to our society and children and teachers?
Yeah. Currently with the infectivity rate in Florida, it does not make sense, even given all of those other associated concerns. Does not make sense to open brick and mortar schools.
I want to go back for a minute. Commissioner Corcoran, who is a party in this case, being represented by Mr. Wells, he mentioned before at the White House back on August 12th, 2020, he was up in DC, and he he spoke saying that he envisions Florida will be up to 80% enrollment of its students and 95 to 100% of its teachers by the end of September. If that's the case, and if Corcoran or Commissioner Corcoran is correct, and 80% of Florida's 2.5 million children are back in schools by the end of September, can parents and citizens of Florida expect them to be safe if they're in brick and mortar schools?
And the only way that is possible if somehow the virus disappears from Florida, which I don't think anybody anticipates is going to happen. So where we stand and what we know today, it doesn't make any sense to have that number of students with in-person teaching, with in-person education in Florida.
Right, but specifically, Dr. Burke, could those students, and I can infer it from what you said, but I want you to answer directly if you could, please. Could those students and their parents expect them to be safe in brick and mortar schools at the current infection rates and at 80% of students back in brick and mortar? Is that possible?
They will not be safe.
What about the teachers? If Commissioner Corcoran's correct, and of Florida's teachers, if 95 to 100% are back, as he indicated at the White House on August 12th, 2020, which has already been pre-marked and has already been entered as an exhibit, if that's true by the end of September, is there any way teachers could be safe and secure if they're in schools, if those are the facts at brick and mortar schools?
Yeah, they cannot be safe.
Even with all the mitigation that we've talked about, potentially if the numbers are below a 5% margin.
If they're above 5%, they're not safe. If they're below 5% with mitigation efforts, then schools really ought to open, yes.
But the one point I want to make, and I misspoke there, forgive me, all the mitigation things, as you mentioned before, I have it written down, you mentioned the word in tandem, or the phrase in tandem. You can't just have masks, for instance, and not have contact tracing or proper hygiene or ventilation, correct? You have to have all of them.
Absolutely.
And if you don't have one of them in each school, even if the infection rate is below 5%, it can lead to an surge in infection rates that could end up being dangerous again. Is that correct?
The best practice formula we have that we know to make it safe to open schools and make it safe doesn't mean it's going to be 100% safe. We even know if it's less than 5%, we have risk, but is really what you just described and what we discussed, which is we need to be below 5%. We need mitigation efforts such as masks, able to be cleaning, able to have PPE, and certainly need to be able to have contact tracing.
Thank you. Your Honor, may I have one moment, please, just to review my notes?
Sure, yes, sir.
Thank you. A few more questions, if I may, Your Honor, just a few more minutes. Thank you. Dr. Burke, God forbid if there is an outbreak or an upsurge, what would we need to do as Floridians to stop that from happening?
Yeah, we need to actually, shut down the state. If there's a sudden surge where you suddenly move back to, or beyond the high numbers that we're seeing a few weeks ago, to really get your arms around that, you need to shut the state down.
Meaning all non-essential work and movement from someone's home or residence would need to be cease to exist to stop the spread of the virus?
Absolutely. You'd overwhelm hospitals, and people would be dying in even higher numbers than we're seeing now.
Is it fair to say, Dr. Burke, that in your experience and your studies, has America or the world ever faced a pandemic like this before?
not in our lifetimes.
Well, that's what I mean. Obviously, we can go back to the Renaissance and some other things for sure. But I meant, I guess in the past, since the Spanish flu, right out or during or right after World War I, depending on which perspective you're looking at. But in the past, 80 to 90 years, that we've never dealt with anything like this before. Is that fair to say?
We have not.
Okay. Thank you, Dr. Burke. It was a pleasure to meet you face to face. I appreciate your time. No further questions, Your Honor.
Cross.
Yes, thank you, Your Honor. Dr. Burke, my name is David Wells. I represent the governor, the commissioner, the other defendants. Thank you for your time today. You mentioned multiple times a 5% number. 5% of what? How's that number calculated?
Yeah, it's 5% of a positive rate of the testing that's occurring. So if you're testing, and it really does need to be, you need to remove double. So and you need to remove actually all these athletes as well. But so often hospitals in particular or other workplaces require 2 negatives, and so if someone gets 2 negatives, it should be per person. So it's a 5% positive rate or less.
So meaning that if 5% or more of the people tested are positive, that's when you don't open the schools.
That's correct.
And you mentioned when Mr. Stewart was asking you questions about an outbreak, that there would be the potential for shutting the state down to everything except for essential services. What percentage is that?
What percentage is what?
What percentage would you say we have to shut the state down?
Yeah, I think that, we're learning as we go. So it really comes down to tolerance of lives lost. And what are we going to tolerate? And those are going to be, certainly decisions made at the, at the CDC and the state level. So I'm not going to sit here and tell you what you're willing to lose in terms of your own family members and as a state. But today I think, or yesterday, Florida lost more than 200 lives, and some significant multiple of that became permanently injured. So what are you willing to tolerate? That's going to be the ongoing question. That's going to drive the decision. But undoubtedly, if you're climbing in numbers and your death rate is climbing, the only way to decrease that climb is going to be to back off in the interactions of the population with one another, in order to break the chain of transmission, to wear masks, and to do all the things that we know in terms of our own personal hygiene.
I mean, if I hear you, you're not giving me a particular answer because you're saying it, or a particular percentage, because you say that's a horrific policy decision that someone is going to have to make in the trade-off between the economy and lives. That's what you're saying.
Yeah, that's right.
Okay. And in your view, in terms of the trade-off between the need for education and what education brings, that there should be no opening at least until it's below 5%. That's where you would draw that line.
That's right. And that's best practice, WHO, CDC. I didn't make up that number, obviously.
I understand. I'm just asking you, that is your opinion. That's what you're telling the court. That's where that line should be drawn.
Yeah.
Now, talking about the need to be back in school, on the idea of domestic violence, you've actually written a couple of articles that are referenced in your curriculum vitae, haven't you?
I have.
Okay. And as I understand it, what those articles lay out is that staying at home because of the coronavirus not only places survivors of domestic violence at risk for further violence, but it also isolates them from networks of support.
Yes.
One of the networks of support is school. And I think some of your research found that reports on domestic abuse of children have gone down with the children not being in school. No teacher to see the red flags.
Absolutely.
Okay. and that in fact the teachers are a good, I don't know, I call it canary in the coal mine, whatever the right word would be, to help the Division of Child and Family Services and others to know that there are problems going on with those children.
That's correct.
Okay. And you'd agree with what the American Pediatric Association and the CDC has said about the need to get children back into schools to be able to give them better learning than the virtual learning.
I agree, but the CDC and the AAP, especially the AAP very recently, if you look at their website today, have come out to clarify, which has been interpreted as we need to push hard to open schools. They've come out and clarified only if safe, only if the mitigation factors are in place.
I think nobody would argue that the CDC and the APA, even your Harvard T.H. Chan School of Public Health have all said it's good to be back, but don't do it unless it's safe.
Right.
Okay. And in fact, you mentioned plans and the fact that if you're going back to school, there should be plans and there are various things that schools need to look at based upon the particular school, correct?
Yes.
And there are guidelines that have been put out. In fact, the Harvard T.H. Chan School for Health provided a document in June of 2020, risk reduction strategies for reopening schools. Are you familiar with that?
I am. It's a little outdated, but yes.
Well, we're moving so fast that June's outdated in August, but I understand.
Right.
Okay. And similarly, the CDC and APA and others have provided a listing of various mitigation strategies that the different schools can use.
That's true.
Okay.
Yes.
There you go. No further questions.
Any redirect?
Just briefly, Your Honor, if I may, sir.
Sure.
Just a few things, Dr. Burke. First, your testimony about not knowing or not being able to say what a exact percentage is in terms of an infection rate to close everything down, you're saying that because that's not your position in your role. Is that correct? Where you currently work?
Absolutely. It's not my decision to when you shut businesses down, when you choose to shut down your economy to, based on level of pandemic within your community.
And true, that's a political decision. But in terms of opening schools, your testimony is unequivocally clear from my perspective. I want to clarify that there should be no schools open unless it's below 5% infection rate, correct?
That is correct.
Right. And then if there is a percentage rate in a county of one of the 67 counties of the state of Florida, it would need to have all of the mitigation required and it be done in tandem and done effectively, including contact tracing, mask, proper hygiene, social distancing, all the things we've talked about for it to prevent a new outbreak. Is that right?
Are getting well beyond redirect, and we've now got Mr. Stewart testifying.
Just be sure, this is just redirect.
All right, so Judge, and one other thing, you mentioned before with Mr. Wells about a prior article in regards to domestic violence. I believe we touched on it, but I want to clarify your position. You testified before that, of course, children are better to be in school, especially when dealing with domestic violence. Is that right?
I did but also if you look at what I wrote that the imperative is, if you look at Lancet piece that I wrote, the imperative is to ensure that communities also have strategies in place for virtual learning, and that domestic violence and child protection community services need to be established, including in a virtual time. In order, and it's not to say that overtakes the concern of health and survival when the rate is above 5%.
Okay, that's what I thought. Thank you, Your Honor. I have no further questions for Dr. Burke.
May Dr. Burke be excused?
Yes, sir. Plaintiffs.
All right, Dr. Burke, you are free to go. Thank you, sir.
Thank you,
Your Honor. And Your Honor, before I turn it back over to Mr. Meyer, my colleague, there's a few things I'd like to introduce into evidence based upon the testimony of Dr. Burke. if I may proceed, Your Honor, with the plaintiff's exhibit list. Is that all right?
Sure.
To be sure, to make sure I have everything taken care of, there was, it's item number 57 in plaintiff's list, the American Academy of Pediatrics update. There is 61, which is or plaintiff's item exhibit 61, which is the Kaiser Family Foundation.
Okay, can I just slow you down? You said 57?
Yes, sir.
That's COVID-19 planning consideration. That's what I have. Hold on a second. I mean, I heard you saying something different. That's why I asked. And Your Honor, if we disappear, it's because we're in the middle of a wicked lightning storm. And
Yeah, I've
lose the internet when that happens.
Yeah.
Well, let me move away from 57 for 1 second to get that taken care of, because you're right, Mr. Wells. I miswrote that in my notes, and I'd asked Mr. Whelan to help me with that. I'm looking in particular for the American Academy of Pediatrics update that came out today. That's an exhibit we disclosed. But before that, item 61, which is what to do about transmissions, and that's the Kaiser Family Foundation one, Your Honor. I also have which has been previously disclosed, the curriculum vitae for Mr. Burke, which is item exhibit number 46. And I believe the other items have been already entered into evidence, the list I'm looking at. But the only issue I have is the American Pediatric. Just 1 second.
We get out there.
You know what, your judge, just to save time, if you would just allow me to revisit that once I get my notes taken care of, and I can bring that back up to your attention, sir.
So right now you're asking for 61 and 46.
Yes, sir.
Any objection to those two, Mr. Wells?
No, Your Honor, and I don't think I have an objection to the other one. Let's just get cleared up on the exhibit number, Mr. Stewart.
And I have one more, Judge, if I may. The exhibit number 47, which is the contract tracing study from the CDC of the United States regarding South Korea.
No objection, Your Honor.
So 61, 46, and 47 are admitted.
All right. And if we just table that until after the next witness, Your Honor, to allow us to get organized, I apologize for the inconvenience.
Okay, call your next witness.
Your Honor, our next witness will be Mr. Andre Escobar, who is, I believe, in a waiting room, and Mr. Whelan will conduct the direct examination.
Okay. Mr. Escobar is in. Okay, Mr. Escobar, if you'd go ahead and just unmute your device there. There you go. If you'd raise your right hand, please. You swear the testimony you're giving today be the truth, the whole truth, and nothing but the truth.
Yes, I do.
Thank you, sir. You can put your hand down.
Andre, good to see you today. How you doing?
You good? How about yourself?
Doing all right. Just as a preliminary matter, we have a court reporter here typing everything we're saying. They're typing everything we're saying up. If you don't understand any of my questions, want me to repeat or rephrase, just let me know. Obviously, with Zoom, there can be some technical issues, so don't hesitate. If you can't hear me or if something doesn't come across, just let me know, okay?
Okay.
Can you state your full name and spell your first and last name for the record, please?
Andre Escobar. It's Andre, and my last name is Escobar.
Perfect. What's your date of birth, Mr. Escobar?
November 29th, 1984.
Perfect. And just tell me what county you're a resident of.
Osceola County.
Perfect. And do you teach in Osceola County as well?
Yes.
All right. Let me get a little background from you, Andre. Where did you attend high school?
I went to a number of different high schools. I started at Northeast High School in Fort Lauderdale, then Piper High School in Sunrise, and then I moved up to Michigan to finish out my high school year in Petoskey, Michigan.
Fair to say you've attended some Florida public schools.
Yes.
You're currently teaching at one.
Yes.
Perfect. Did you get after high school? Did you attend college?
Yes, I did.
Where'd you go for that?
Nova Southeastern University.
Did you get a 4-year degree?
Yes.
What was your 4-year degree in?
In secondary education in mathematics.
Perfect. Any schooling after Nova Southeastern?
Not after Nova.
After you graduated from college, what was your first job?
Teaching high school math,
And where are you currently teaching?
Gateway High School.
Is that where you started teaching?
Yes.
And how many years have you been there?
I believe this is going to be my 8th year.
What grade level or grade levels do you teach?
I've teach all grade levels. I've taught pretty much every topic that we cover in high school as far as math goes.
Taught basic, let's say algebra all the way up to AP or honors courses.
Yes, I've taught, basic algebra 1 to all the way up to IB high level math.
How many students are at your high school typically?
It's about 2,500 or so, but that fluctuates.
Since you're at a high school, are those students rotating amongst classes?
Yes,
How many classes per day do these students have?
I believe 8.
Okay. And how many courses do you teach per day?
I teach 6.
Typically, how many students are you seeing in and out of your room per day?
I'd say an average of 30.
And that's per class?
Yes.
So just estimating about 180 to 200, would that be pretty fair to say per day?
Yeah, that would be fair.
Obviously, and fortunately, some of the parents have chosen to keep their kids home and do launch ed, or that's what we're calling in Orange County. I don't know what they're calling it in Osceola County, but an at-home virtual program. Is that fair to say?
Yeah.
So as it stands right now, Mr. Escobar, how many students do you anticipate seeing on a daily basis if schools are to open brick and mortar?
Me personally, about 60, maybe 50 to 60 students.
Okay. So would that average, give or take, about 10 plus per class?
Well, for me, I have only two face-to-face classes where they're blended. And I believe I have about 25, but they're not done scheduling yet. They're still working out. Some students are still calling in to do face-to-face and, vice versa. So I have 2 classes with about 25 students or so.
Well, I'm a little bit confused. So rather than staggering them out over 6 courses during the day, they've condensed them all into a couple courses?
No. So I have 6 courses. I teach 3 geometry classes, which are all digital. There will be no face-to-face with the geometry courses. And I'm going to teach 3 pre-calculus classes, one of which is to be digital, but the other 2 will be blended. We'll have some students in the class and some students out of the class, distance learning. And those 2 classes that are blended, I'll have about 25 students in the class, last time I checked.
25 students per class?
Yes, per class.
Okay. And typically, what type of room are you in?
For the 7 or 8 years that I've been teaching, I've been in a portable.
Has that changed in the past 24 hours?
Yeah, just this afternoon, my principal that has been really working hard to try to accommodate me as a teacher because of my situation, to be able to, limit my exposure to students as much as possible.
Let's talk a little bit about that. Do you have any underlying medical conditions?
Yes, so I'm a C4, C5 spinal cord injury, quadriplegic.
What does that mean, Mr. Escobar, for those of us who aren't familiar with paralysis, if you will?
So because my spinal cord is injured, the nerves between my brain and the rest of my body, it's like the signals that go from my brain to the rest of my body are impaired. So I have a partial paralysis in my legs, in my hands. I don't have function. I really don't have function of my fingers. My trunk, I have very weak abdominal muscles, if any. My right leg is very weak. My left leg is kind of strong, but I have limited feeling from my chest down. From my chest up is kind of normal. From my chest up, I would say everything is about normal, but from chest down, everything has some sort of impairment or paralysis.
You said from your chest up, it's pretty normal, but do you have any type of weakened pulmonary system? Are your lungs
Yeah,
weakened
so-
by this condition?
Because of my weak stomach muscles and lungs, and diaphragm, it's really hard for me as a person as any quadriplegic to be able to cough and, get rid of like mucus and that kind of stuff. So, I imagine that some disease like COVID would be, really harmful for me. As it is, when I get sick, I'm more susceptible to things like pneumonia because I can't expel the the mucus and the stuff that's inside your lungs and respiratory system.
What's your understanding of what might happen to you if you come down with COVID?
When I spoke to my doctor, it said that I would be very unlikely to survive. It would be grave.
I'm sorry to hear that. Mr. Escobar, let's go back just generally to your condition. Obviously, we talked a little bit about what's going on as far as your legs and your arms and your trunk, if you will, as well as your pulmonary function. How do you ambulate? How do you walk around the classroom or move around the classroom?
In the classroom, I use a walker. I have a kind of a special platform walker that is a little bit higher. I walk slow, but I get it done in the classroom. That's how I ambulate in the classroom. Outside of the classroom, I use a scooter.
Describe that scooter. Is that like a motorized scooter that you use to get around the school?
Yeah, it's a motorized, 3-wheel scooter that, goes around a lot faster than I could walk.
I understand. All right. As a part of having this condition, Mr. Escobar, did you put in a request to your principal or to the school board in Osceola County to be accommodated?
So I first called the Osceola, the district, to see what my options were because of my condition. And the only options they gave me were 2 weeks paid leave because of the CARES Act. Then after that, I would have available FMLA. But other than that, I really didn't have any other options. I was either going to teach or have to quit. And they recommended I talk to my principal. And I've been talking to my principal. We've been in constant communication, trying to figure things out, especially my assistant principals, they're trying to schedule it around me, especially because of my condition, and be able to have as much digital distance learning as possible.
Let's go back just for a second. You mentioned FMLA, Family Medical Leave Act.
Yes.
Were you told that if you take FMLA, that will be paid or unpaid?
Unpaid.
Okay. And I know that your assistant principal and your principal are trying to work with you, but as it stands now, have you been required to return to the classroom?
Yes.
And teach students live in your classroom?
Yes.
Okay. Are there any other teachers you know of that put in for accommodations that have not been granted?
Yeah. There's teachers that have asked to do all digital, but the school and the principal are kind of at the helm of what they get in students, and they're kind of stuck in scheduling. And the district we don't have many other options that they can exercise to give us.
Okay. As it stands now, are masks required at your school?
Yes.
Have you seen, are masks required for students, and are they required for teachers as well?
Yes, for both.
Have the students returned to your school yet?
No.
Have the teachers returned to your school?
Yes.
Okay. And have you seen any of these teachers around campus?
Yes, we've had full staff meetings in the cafeteria. We've had a few meetings.
And has anybody in those meetings, or have all the people been following the masking policy?
No, there's been a few that unfortunately don't follow it, as it's supposed to be followed.
Do you expect the students to follow the masking policy as it's required?
Not if all staff are not. No.
Okay. It's my understanding that Gateway High School may be a Title I school. Is that right?
That is correct.
As a part of being a Title I school, what does that mean?
Specifically at our school, we provide free lunch and breakfast to students. And that's one of the things that we have to make sure that students get, is they get their breakfast and lunch that they're, or at least they have the availability to get it.
And as far as breakfast goes, prior to the pandemic, how would that be handled?
They would just go to the cafeteria and get breakfast if they wanted at their own will.
Has your principal put forward a different plan due to COVID-19?
Yes, because our cafeteria is not large enough to hold all the students at once, and students need to be supervised at all times. They provided that all first period teachers, if you have a class, that the students are to grab their lunch or their breakfast and bring it to their classrooms and eat breakfast in their classrooms.
So the students, just so I'm clear, the students are going to take their lunch from the their breakfast, from the cafeteria and bring it into the classroom. Does a teacher have to be present, or is a teacher expected to be present while they eat breakfast?
Yes, that's correct.
Is the masking policy going to be enforced? I guess, how is the masking policy going to be enforced if they're eating breakfast?
I don't know, unless you can somehow devise a way to eat through the mask without taking the mask off. I don't see how that's possible.
Okay. And generally, masks, are they going to be required at all times throughout the day, meaning in class, while you're walking around campus?
Yes.
Okay. Except obviously when they're eating in the classroom before first period.
Yes.
Okay. All right. I'd like, if we could, Judge, to publish a couple pictures that Mr. Escobar has taken himself of his classroom. They are composite exhibit number 35, if we can get those up on the screen. All right, Mr. Escobar, I think we've got 3 pictures. So let's start with this one right here. Can you see that on your screen?
Yes.
What is that?
That's a picture of my desk, a table in front of my desk, and just a small portion, well, a portion of the student desk.
Okay. And it may not be apparent from the picture, but if you can describe to the judge, are those desks being spaced 6 feet apart?
No, they're not.
How far do you think they are apart, if you, in your estimation?
I would say 2.5 to maybe 3 feet.
Oh, are you in your classroom right now?
Yes.
Okay. I saw you looking over to the side.
Yeah.
Could you tell when you came back to school if your room had been cleaned?
I mean, I can't tell. I don't know how I would be able to tell that now.
Okay. Are you going to be required to clean your classroom?
Yeah, as of my understanding, we're required to clean between periods. We're supposed to spray down and clean the desk between each period.
Practically, with your with your paralysis or with your condition, is that something that you can possibly do to clean that many desks before the next? So how many minutes between classes do you have? Would a person have to clean those desks?
I believe 6 to 7. I honestly don't remember the time frame.
Okay, but I assume kids kind of filter in slowly throughout, so it's not a set 6 minutes before they walk in the door. They're
Correct.
coming in typically as the day progresses.
Correct. Yeah, I've had kids come in, 30 seconds after the bell rings for my class to leave. So yeah.
Are you familiar with the term PPE, Mr. Escobar?
Yeah, I've heard it.
Okay. So personal protective equipment is, I believe, what it stands for. What have you been provided as a teacher at Gateway High School as far as PPE is concerned?
So far, we've been provided masks and Kleenex.
When you say Kleenex, are you referring to, if you've got a runny nose, you grab a tissue or a Kleenex?
Yep.
These are not Kleenex branded wipes that have alcohol or some other cleaning agent in them?
No.
Have you been told that you're going to receive some type of cleaning device to clean the desks as you've been told you have to?
Yeah, we've been told that we're going to receive the spray bottles to clean desks. Yeah.
When is school supposed to start, Mr. Escobar?
It's supposed to start on Monday, the 24th.
And do you have any of that stuff yet?
No.
Okay. Due to your condition, you're at an increased risk. Has your school provided you with any additional safety measures beyond what a normal teacher gets?
No.
Have they provided you with a sneeze guard or plexiglass to put in front of your desk so you can stay behind your desk away from the students?
No.
Have they provided any additional hand washing stations in the classroom?
No.
Describe to me the bathroom situation at your school. Typically, before the pandemic, would there be a line between classes sometimes for students to use the restroom?
Yes.
And has there been a change to, either monitoring people's use in the restroom so people aren't lining up behind each other? Or has there been any recommendations about how often children are supposed to wash their hands, or teachers are supposed to wash their hands?
No, they're still trying to figure things out. I mean, I don't know how it's very sensitive. I don't know how we're supposed to monitor students in the bathroom.
School, or you're at a high school, so kids rotate between classes. I think we established that.
Yes.
Has there been any discussion about staggering the switching of classes so there are not as many children in the hallway?
No, not that I'm aware of.
Okay. What training have you received from either the Department of Education, the Department of Health, or Osceola School Board about how to handle COVID-19?
None.
Has anybody come in to provide training to the staff or the teachers?
No.
Have you been provided any social distancing training?
No.
Are you being told how you're supposed to enforce social distancing and masking policies?
For the masking policy, yeah, our principal told us that if we get students that don't have masks or refuse to put on the mask, to send them to the front office, at which point they would be told they have to wear a mask or attend distance learning.
What about social distancing?
I don't know how we're gonna make students. I mean, as you can see, the classrooms, they're not 6 feet apart. It's almost impossible to have 25 desks in the size classrooms we have to put them in, have them 6 feet apart.
And I think we're scrolling down here. Is that another picture, page 2 of 3 of this exhibit? Is that another picture of your classroom?
Yeah, that's correct.
Talk to me about the ventilation system in your classroom. I mean, and when we return to school in August, let's say, is the ventilation system, you believe, up to par and will be safe?
I wouldn't trust it. Yeah, I don't know. I'm looking at it right now, so I'm looking at that because the portables have their own AC unit. We have AC issues all the time. I mean, just this morning in the building, the AC wasn't working. I'm just fortunate in a portable, we have our own isolated AC unit, so I'm not dependent on the entire system. So if the system goes down, I still have AC, but if my AC goes down, then my AC goes down, which it has in the past.
Have they provided you any new filtering system for your classroom, any air purifiers or updated air filters that are specifically designed to keep COVID-19 from being passed through the air conditioning system?
No.
Is there any plans to do any of that? Have they talked to you about that?
Not that they haven't talked to us about that, no.
Okay. Do you know of any plans when the school year starts to have the Department of Education, the Florida Department of Health, or any other health providers or anybody else come in and train the students on the new rules about COVID-19?
No, I'm not aware of that.
What's the procedure if a student tests positive or has symptoms of COVID-19?
I believe they're supposed to quarantine for 2 weeks, and then they come back to the front office, and if they don't display symptoms of COVID, then they're free to return to face-to-face teaching.
Who's making that determination, Mr. Escobar?
I believe the front office staff. I don't know if it's the APs. I'm not sure. The school nurse, maybe. I'm not sure.
Are they requiring a negative test before somebody is able to return to the classroom?
Not that I'm aware of.
Okay. Have you been offered any type of flexibility in your work schedule given your underlying condition?
No.
Has the principal talked to you about being in a lower risk area due to your paralysis?
What do you mean by lower risk area?
That's been brought up by the defense as a possibly as a way to mitigate teachers who have underlying conditions, that they could be put in a quote lower risk area. Has that been offered to you or even discussed with you?
I mean, they're trying to reduce the amount of students that I would see face to face. But I don't know. I don't understand, because if you're still seeing students, aren't you still at risk? I mean, a lower risk area to me would be digitally or not seeing face to face students, or having them so far apart that it wouldn't be, you know, you wouldn't be at risk of catching any kind of, virus from them.
You were teaching in the spring of 2020, correct?
Yes,
When we went digital, what, right after spring break?
correct.
There's been a lot of talk about students falling behind. In your estimation, did you notice a substantial increase in the number of students falling behind due to going online?
No, I just had students, in my class, students did better, like grade wise. They were able to do their work, and they got better grades than they normally would have.
Okay. The last year, if there was a student that was struggling, were you still able to spot that student through the online system?
Yes, absolutely.
Were you able to offer additional assistance to that student?
Yes. In fact, I think, this is my personal opinion, but when due to the way that I was running the online classes, I was able to group. So right now I have 3 geometry classes in their separate periods, but I was able to kind of like clump them together. When I teach one lesson, I taught all 60 or 75 students at once. So then that freed up more time for me to do like one-on-one sessions with individual students. So I was able to reach more one-on-one students than I would normally on a face-to-face basis.
Did you provide additional assistance to those students, not only for additional time, but fortunately you're bilingual, is my understanding?
Yes, yeah. I always offer to teach in English and Spanish to my students. I just, try to get them to learn the material.
And are you aware of other teachers making similar accommodation for those students when everybody was online in the spring?
Yes, we had, paraprofessionals or ESOL professionals they were getting online and making sure students were not falling behind. They would call parents, and they were helping out with that part of the distance learning of calling parents. That part was kind of difficult for us, because teaching and then calling parents was time consuming.
Of course. And we're not sitting here saying the online system was better, but my question to you, Mr. Escobar, is if you were permitted, or if the school board was permitted and given the right by the governor and the Department of Education to make their own decision about when to return to school, and that might include delaying the start of the school year, is that something you think that we could still work through in an online system for at least a temporary period of time?
Yeah, just because we just started right now, and they've introduced a bunch of new digital applications to be able to support students and monitor students. And it's been really, like, normally, beginning of the year, we're a little bit overwhelmed because we're trying to get everything together. We have to do everything in a week. But this time it's on a new level of, we have so many new applications, which they all sound great, and we want to learn how to use them, but it's a lot and a little bit of time to start trying to implement them with such little time of training and being able to practice with them.
Do you feel like you've been properly prepared to return to the classroom, though, Mr. Escobar, to avoid COVID-19?
Oh, absolutely not.
Are you concerned? Tell me a little bit about your concerns, Mr. Escobar, about given your condition. I know that you're paralyzed, essentially from the waist down, or at least have extremely limited mobility. Tell me about your concerns being forced back into the classroom.
Yeah, so I'm not scared, because I don't live based off of fear or anything like that. It's just that I understand the risks that I would be taking. I have a wife and son at home. I'm basically the main breadwinner in the home. My wife has a little small business, but it's not anywhere near that we'd be able to just quit and go home and give up teaching just so that I would not be at risk. And if I were to, catch COVID and be in that situation, it would be very damaging to me and my family.
We had a teacher that testified a little earlier that he's probably going to have to retire prematurely if he's required to go back into schools. You don't have that choice, though, do you, Mr. Escobar?
No, I can't retire.
Well, is that, like you testified earlier, is that due to the fact that you've got a wife and child to support?
Yeah. Also, I've only been teaching 8 years. I don't know. I don't think I'd make enough during retirement to, to survive off that. I've been doing my due diligence to try to apply other jobs to have just a backup in case I was put in a very difficult situation. But because my degree is, specialized in education, it's hard to, just because I have a bachelor's doesn't mean that I can qualify for other working positions to be able to transfer and work in another field.
Yeah, tell me a little bit more about your background, Mr. Escobar. Obviously, you went to Nova Southeastern. Was it your intent, or how early on was it your intent to become a teacher? Obviously, you got a degree in essentially teaching, but
yeah. So I went to Broward College for a couple years. I got my degree in finance, which I wanted to get just so I can work a bookkeeping job while I went to a 4-year degree. But I quickly found out that you need more than an associate's degree to be a bookkeeper for the most part. So, but I ended up getting a scholarship, and my full intent was to teach, high school math, be a coach, an athletic coach. I coached here for about 6 or 7 years. Recently, stopped doing that so I can spend more time with family. But yeah.
Well, tell me, when did you decide to become a teacher?
I've always had an enjoyment for math, and I've always loved to tutor my friends and other students. So about 2010 is when I decided, I really want to pursue this and be an educator.
And just so we're clear, did you have to go back to school and essentially start a new degree to a certain extent to then get a degree to become a teacher?
No, because when I graduated from Broward College, I had I had basic credits. So when I went to, I guess a little bit, because I would have normally just had to do 2 years at Nova Southeastern, but because I didn't have any of the education credits, I had to start, and it took about 3 years to graduate from Nova Southeastern.
Gotcha. And did you have any student loans or anything like that from Nova?
Yeah. Yeah.
And are you using your teaching salary to try and pay those off, or are you hoping those will be forgiven under a repayment program of some sort?
Yeah. Part of it has been forgiven. I was planning on, at the very minimum, making sure that I taught for 10 years so that all of my student loans would be forgiven.
So if you had to quit or change professions, not only would you have to forfeit your 8 years of history and teaching, whatever retirement benefits might come with that down the road, your salary, but also potentially your loan forgiveness.
Yes.
Okay. I just got a few more questions, Mr. Escobar. I appreciate your time. I know it's probably not very comfortable to sit still this long, especially with your condition. As it stands now, based on what you know specifically, Mr. Escobar, as a teacher of 8 years and what you've seen in your school and in your community of teachers, do you think it's safe for us to be forcing teachers back into the classroom before the end of August?
No.
Okay. And have you been able to see some of these statements that might have been put on the news, or maybe even a part of our case, that the governor and the Department of Education, Commissioner Corcoran, have said, look, we should give parents a choice, but also teachers should have a choice and they shouldn't be forced back into the classroom. Have you seen those statements?
Yes, I have.
Given the ongoing pandemic, would it be if it was your choice, would you return to live face-to-face instruction?
No, I would not.
So do you believe, according to what the governor and the Commissioner of Education have said, do you believe that you even have a choice?
No, I don't.
Okay. Other than the choice obviously being to forfeit all those things we just talked about, quit your job,
yeah,
and then try and find a new career.
Right.
Or return to face-to-face instruction.
Correct.
Your Honor, the witness can be yielded for cross-examination. Before that, I would like to move into evidence the images that Mr. Escobar took himself and testified to. They are plaintiff's exhibit number 35.
Any objection to number 35?
No, Your Honor.
Plaintiff 35 is admitted. Cross.
Thank you, Your Honor. Good afternoon, Mr. Escobar. First of all, thank you for testifying here today, and thank you for being a teacher. I am also a product of the Florida Public Schools, and as it happens, of Gateway High School. So I know that teachers can be an important part of a student's life, and I'm sure you would agree with me that teachers are very important for students. Is that right?
That's correct.
And I'm sure you'd probably also agree with me that remote education is no substitute for an in-person teacher. Is that right as well?
I mean, I just depends on the student, but I think most students prefer in teacher, education, but a lot of students, I mean, there's few students, or I don't know how many, but I would say there's a percentage of students that prefer online education and the flexibility that it provides.
So do you know approximately how many students chose to return in person, just as a percentage in Osceola County?
Not in the county. I think in our school, we were almost 50-50, I think, but the majority, I believe, at our school were choosing to do digital. I mean, but a slight majority, I think.
Okay, so somewhere around 50-50 chose to come back. Is that what you're saying?
Yeah, I think so.
Okay. And I believe you also said that the school district and the school board was going to try to offer teachers an option to teach virtually or teach in person. Is that correct?
The school district, they said that teachers would have an option to teach remotely or to be face-to-face. They would have to communicate with their principal.
And in fact, you've asked for an accommodation like that, haven't you, to be able to teach remotely
Yes.
for as long as possible, right?
Yes.
But the reason why you can't do that, and why maybe some other teachers might not be able to do that, is because a lot of students have chosen to come back to school. Isn't that right?
I don't know if it's directly related to the amount of students that have chosen to come back, but just the difficulty in scheduling they're having. They're having difficulty in just scheduling, period, the number of students for teachers.
Well, if less students chose to come back to school, there's a much greater likelihood that you would have actually been able to stay as a remote teacher, right? Would you agree with that?
Yeah.
And you also have a contract with the school district, don't you?
Yes.
And that contract is part of a collective bargaining process with the union, is that right?
Yeah.
Are you a member of any teachers' unions?
Yes, I'm a member of Osceola's union.
And you know that your contract has a grievance procedure in it that has arbitration provisions and things like that?
Yeah, I believe so.
I'm sorry?
I believe so.
And so if you have, if you were improperly fired, if you have a dispute about your working conditions, you would be able to bring a claim under your contract against the school district, wouldn't you?
I haven't had to use that or do that, so I'm not aware of the procedures of that process.
Okay, fair enough. May I have a moment, Your Honor?
Sure.
Thank you very much, Mr. Escobar. I have no further questions, Your Honor.
Any redirect?
Briefly, Your Honor. Mr. Escobar, what was communicated to you as to request or how to request an accommodation?
To speak to risk and benefits. And then I spoke to them and they told me to speak to my principal, and my principal's they do what they did, but he told me that they were required to give those cases, refer them back to district.
So essentially, that was not, your request was not accepted.
Correct.
Okay. And you're being forced to return to the classroom for live instruction.
Yes.
And I know you're unfamiliar with the grievance procedure, but based on your understanding, do you think a grievance procedure is even plausible at this point in time with us returning to school on Monday?
No.
I'm sorry, can you answer that again, just for the record?
No, I don't believe so.
Okay. As it stands now, are you being forced to make a choice between returning to the classroom or and putting your health at risk or losing your career?
That is correct.
I have no further questions, Your Honor.
May Mr. Escobar be excused?
Yes, he may.
Yes, Your Honor.
Mr.
Yes,
Escobar, you're free to leave the meeting. Thank you, sir.
Thank you.
Your Honor, I'm going to ask Mr. Stewart, who I believe has now got the exhibit numbers correct, toss it over to him, and then afterwards, Ms. Aguila will address the evidence that we yet have to move into the record.
Thank you, Mr. Meyer. Your Honor, I apologize for the inconvenience before. I just screwed up my notes. If we could proceed, there's several exhibits you want to move in. First is Plaintiff's Exhibit 3, CDC Activities Initiatives for COVID-19 Response. There is, Mr. Wells, can you hear me as well too, sir?
Yes, I just had to get the, sorry, my eyes are really a problem this afternoon, so give me a second. Exhibit 3?
Yes, sir.
CDC, yeah, that's fine.
Yes, sir. Exhibit 4, the World
Hang on a
Health.
second. Hang on a second. Exhibit 3 is admitted.
Thank you, Your Honor. May I proceed?
Yes, please.
Yes, sir. Plaintiff's Exhibit number 4, World Health Organization Public Health Criteria to Adjust Public Health and Social Measures in the Context of COVID-19.
No objection.
Plaintiff 4 is admitted.
Plaintiff's Exhibit 7, Transcript for CDC Telebriefing on New Resources and Tools to Support Opening Schools.
No objection.
Plaintiff 7 is admitted.
Plaintiff's Exhibit 13, AAP and CHA- Children in COVID-19 State Data Report.
No objection.
Plaintiff 13 is admitted.
Have exhibit number, last one is Exhibit 57, which is the COVID-19 Planning Considerations Guideline for School Reentry.
No, no objection.
Plaintiff 57 is admitted.
And that's all I have at this moment, Your Honor. Thank you.
Your Honor, I believe Ms. Aguila is prepared to provide the listing of our other exhibits that need to be admitted. She's going to be on Mr. Coffey's microphone.
Ms. Aguila.
Hi, thank you. Okay, going through the remaining exhibits. Exhibits 1 and 2 are Department of Health press releases. So we wanted to move into
1 and 2.
Yeah. Is there any objection?
No.
So 1 and 2 are admitted.
Number 6 is also Department of Health press release.
No objection.
Plaintiff 6 is admitted.
And number 7 was just admitted, correct?
Correct.
Okay, number 9 is a public records request that we made to the Florida Department of Education. Number 9 and 17 are both letters from our law firm to the Department of Education.
Any objection to 9 and 17?
Well, I don't know what the relevance are of public records request in this matter, Your Honor.
We've also included the entire production from the Department of Education as composite exhibit 48. And those are documents we will likely be relying on tomorrow.
So
Yeah.
there's objection to 9 and 17 based on relevance.
Yes, Your Honor. And then the Exhibit 48, if I read this right, is 1,100 pages that we have not had the opportunity to review and decide on an individual basis.
They were produced by your client.
If pursuant to a public records request, and now you're asking to put in 1,100 pages of documents. And our objections, we have not had a chance to review each of these individual documents to know which ones may or may not be appropriate to be in.
I think those objections are well taken. I'm not going to allow 917. I may or may not allow 48, but I'm not going to just do a blanket admission of 1,138 pages just because they were produced.
Okay.
They're the documents the DOE relied on in making the emergency order.
Okay. The request for the public record request specifically asked for documents relied on in making the emergency order, if the relevance is any help. But we may rely on them individually tomorrow.
Okay, any others?
21 and 25 are also related to the public record request, so those will all be grouped together.
21 and 25, the same objection, Your Honor. Now we're talking about the responses to the request.
Same ruling, 21 and 25 will not be admitted.
And then we have a series of declarations. The parties agreed beforehand that we would be submitting some evidence by declaration because we wouldn't have time to present all of the witnesses. So that's Exhibit 10. Dr. Horihian, she actually submitted the same declaration as part of our motion for injunctive relief. So that's already on the record.
No, you can just say the numbers if they've already been agreed to.
Okay. Number 10. Number 16. 18, 19, and 20. 22 and 23. 32, 33. And number 60.
On 60. Okay.
Any objection to those, Mr. Wells?
No, Your Honor, we agreed on both sides, given the amount of time.
Plaintiffs 10, 16, 18, 19, 20, 22, 23, 32, 33, and 60 are admitted.
Exhibit number 14 is the Hillsborough County agenda of the August 6th meeting that was discussed with the first witness.
Any objection?
No, Your Honor.
14 is admitted.
Okay. Okay, number 26, 28, 29, 30, and 31 are the Department of Health's daily reports for these counties, Hillsborough, Manatee, Orange, Osceola, and the state of Florida for COVID-19. It tracks hospital beds, positivity rate by state, by county daily.
Any objection to those?
I'm sorry, I got lost when I saw the reports. I thought, Ms. Aguilar, I thought you were talking about the school reports. So 28, 29, 30, and what was the other one?
I think it was 26, 28, 29, 30, and 31.
Okay, and those are just the reports for those particular days is what the COVID rates were. No objection.
All right.
Those are admitted.
Okay, Exhibit 34 is the sources, the bibliography from the composite video of Governor DeSantis and Richard Corcoran.
I'll make the same objection we made earlier, Your Honor, but you've already ruled, so I don't know that keeping the bibliography out makes any difference.
Right, so same ruling, 34 is admitted.
Okay. Okay, and then the last two, Exhibit 62 and 63, those were used during the direct of the Chief of Staff of the Department of Health. It's the subpoena we issued and the document response.
You mean the response documents?
Yes,
that you put up. Yes, okay, no objection.
62 and 63 are admitted.
that's it.
Okay, what can we do next?
34.
Your Honor, we still have pending a motion for leave to file an amicus brief, which was filed by a group of other organizations, as well as a motion for admission pro hac vici for the attorney who prepared the brief. Your Honor, we'd like
No
a
objection,
ruling
no
on this.
objection, Ron. We don't object. We don't object.
So it's my understanding the state does not object. So if we could grant the pro hac vici and grant leave for the amicus to be received, I believe that's all of the remaining issues we have before you today, Your Honor.
All right, both are granted without objection. Now, is the plaintiffs finished?
Yes, Your Honor. We're resting.
Plaintiffs are resting. Anything we can do to get started on the defense case today, Mr. Wells?
I don't think so, Your Honor, just in terms of the folks that we tried to have some folks on standby, but as we got later in the day, we've had to let them go. But I don't see any problem getting our case on tomorrow.
Tell me what we've got left to do tomorrow now.
Oh my goodness. Our witness list here. I know that we're calling Jacob Oliva, who's the chancellor. We're calling Dr. J. Batahama. I'm messing up his name as well. We're calling, sorry, some individual teachers, Your Honor. And who else do we have? I forget it.
We have some Department of Education witnesses.
Oh, some Department of Education witnesses as well, Your Honor, but they'll be brief.
So if we start at 8:30 again tomorrow, what time would you estimate the defense case will be finished?
I would say certainly by this time, and maybe sooner. It's hard to guess on
Right.
what cross-examination is going to look like. Ours, we had some very brief cross today, and yeah, I don't know that I can count on it necessarily tomorrow.
So do I need to start setting aside some time on Friday to finish? I've got a hearing that's supposed to last all Friday morning.
I would say that it wouldn't be a bad idea to use it, Your Honor, but I as you probably saw today, I tend to be brief, and I think that our directs will be, hopefully precise and focused. But I just, between Dr. Batahama and Mr. Oliva, I just don't know how much time these folks are going to take on cross, so it's hard to guess.
Well, we can look at that tomorrow. If we go Friday, it would probably have to start at noon. So I've got a hearing that's supposed to go, I think 9:30 to noon on Friday morning.
Thank you, Your Honor. Just a couple of questions around that. Are you anticipating when we get done doing any type of closing arguments or having any type of closing briefs to deal with all the evidence?
I would love to have that. What I'm getting from the plaintiffs, though, is a strong sense of urgency. And I mean, y'all have given me already quite a few exhibits to go over. I've got a stack of hard copies of the defense exhibits behind me here for tomorrow. And I guess I'll need to ask Mr. Meyer, Mr. Coffey, Mr. Stewart, Mr. Wheeland, how much time I've got to get an order out.
Well, Your Honor, this is Jacob Stewart, by the way. As Mr. Liz testified earlier today, if an order is not entered by, and Mr. Liz, for the record, is one of our plaintiffs and my client, if an order is not entered before the start of school Friday morning.
I know, I heard that. So how in the world is that going to happen?
I understand, Judge, the position that unfortunately you're being put in, but that's the relief we are requesting. Otherwise, it becomes moot for Mr. Liz. So potentially, you know, a temporary order forcing Orange County not to open if you need more time. I'm sure we would be open to that, Your Honor.
Well, let's go as far as we can tomorrow. I just, I mean, with a case of this magnitude, not only the importance of it, but the amount of testimony and the number of exhibits, I would certainly like to have closing arguments tomorrow. I mean, I'll be going through everything I can tonight.
Your Honor, this is Kendall Coffey, and I certainly don't have anything but the utmost respect for Mr. Stewart's clients and their urgency. But on the other hand, rushing into things is not always the best way to open schools, and it's certainly not necessarily, it's really up to Your Honor, but the best way to make what is a truly historic and momentous decision. So I would suggest this. I think Mr. Wells and I, or others who may be participating in the closing argument, may have an opportunity to do so. But I don't want to suggest that that puts Your Honor in a position where this has to be decided, in particular, sometimes without the benefits of post-hearing papers, which perhaps could be even, something could be filed on Friday. But this is a really, really important case. We think we produced some very compelling evidence today, but we assume the other side's going to have their side of it. And Your Honor's not, you know, wants to hear both sides and review the evidence. So I would suggest this way: is there anything that can be done within the Orange County school system if there are some individual teachers who need a few more days to make these important decisions? Is there some way that can be managed or handled so that we're not all faced in a position of having to have a decision in this case by, I don't know, 10 o'clock tomorrow night?
Yeah, I guess just speaking for the state, I find myself agreeing with Kendall on not rushing. I'll leave it to Mr. Stewart to speak with the folks from Orange County, but you're truly talking about a monumental decision here. You're talking about stepping in and saying yay or nay to the opening of, I don't know how many more schools are left to open, who all have plans to open, whose parents have plans to be there, and doing it, you know, on the heels of 2 days of intense testimony and documents without the benefit of the time to look at it in briefing. I would just suggest that Mr. Coffey is right on that, and we should try to do that with the right amount of time. I leave that to Your Honor. Your Honor's the one standing here having to deal with the decision.
And Your Honor, may I just respond briefly, please?
Sure.
This, you know, we filed the suit first of anyone else in the state. We for sure understand the gravity of the situation. This, though, is a motion for the temporary injunction. This is not a hearing on the final complaint. This is the hearing that we pushed forward and down in Orlando. It was set last week. That obviously we agreed to move it up here for a variety of reasons. And for purposes of our clients, and I have all the respect for the 67 counties and what this means, but if there is some type of ability to do a temporary stay in Orange County, that certainly be something we would be open to allow you the proper time to make a final decision and allow us to prepare. But for closing arguments, I mean, my clients totally, just like an opening, we intend, if there are closing arguments, we want to be part of that process in terms of the motion for the temporary injunction, Your Honor.
Well, I don't think I can enter any kind of temporary stay without the defense agreeing to it. And I just don't think I have the authority to do that.
Your Honor, perhaps the defense could be of assistance in speaking with the Orange County School District to fashion some sort of relief temporarily, whether it be granting leaves of absence to those people who are faced with the dilemma that Mr. Liz is, or some other mechanism that would both preserve his career as well as his safety and preserve the right for Your Honor to get to the bottom of this. I think it would go a long way if the state defendants were to work with Mr. Stewart and with the school district in fashioning some sort of relief.
I think, Judge, too, though, that part of our testimony we put on today, especially from Dr. Burke, if the more and more that schools open and the more and more, especially coming Monday, that students and teachers are back in school, before we put Florida on a trajectory for a new catastrophic outbreak. So that's again, the reason we sought the remedy for the motion for temporary injunction relief versus the actual complaint is due to the nature of the pandemic we're in right now, Your Honor.
Yeah, but I don't think, I mean, today we've admitted 50 exhibits.
Somewhere in there.
Maybe about there. Tomorrow I'm going to have a big stack of defense exhibits and more testimony. And I think in fairness to both sides, I've got to make a review of those exhibits. I mean, there have been several that have been made by declarations or other reports from the CDC and other entities. And I don't think I can just look into a crystal ball at 8 or 9 o'clock tomorrow night and make a ruling without reviewing the evidence. I mean, if y'all put that in, I'm assuming you wanted me to look at it.
I understand what you're saying, Your Honor, and I fully appreciate the gravity of again, but from our perspective, if schools continue to open, the testimony that Dr. Burke elicited or was elicited from Dr. Burke will prove the fact that Florida will find itself again in a very dangerous situation. So our purpose of seeking a temporary relief to allow you time to decide on the overall merits of the complaint. I mean, our motion for temporary relief mirrors is almost identical to our original complaint, verified complaint. You would be afforded the time to make the final decision, but certainly you have the right under the temporary relief in the complaint to enter the temporary injunction to allow you to make the final decision, Your Honor.
Your Honor, forgive me if I'm restating it, but we want the evidence reviewed. We want this. We don't want to put Your Honor in a position of not having an opportunity to consider the evidence that's been admitted into this case. And if there's a need, and we will move at your pace, Judge. We'll move as fast as humanly possible. If the court has any interest after tomorrow in some kind of hearing brief, we'll submit it Friday. We'll submit it Saturday. We will not stop working. We know how urgent this is, but it's got to be done in the appropriate judicial way.
And there's no question about that, but every day we go by and allow more teachers and students to be in school creates the effect that we're all trying to prevent. At least both sides can agree to that. We all want safe schools, safe students, safe teachers, a safe society, but we're talking, this case has an impact on over 22 million Floridians. And it would just, from our point of view, from Ms. Belfer, Mr. Liss, Ms. Hammond, and Ms. Monroe, on behalf of them and what their claims are, it would make immediate sense to, from our position, for you to consider the motion for temporary relief. And if you're not inclined to do that, then you would consider the merits of the complaint, which is the way that we originally filed it, Your Honor. Because waiting undercuts what the purpose of this emergency relief was sought for back in July.
Oh, I understand that, but I don't think I can just make an off-the-cuff decision of this magnitude without going over all the evidence. I understand, and I understand the plaintiff's positions. I understand the defendant's positions. So I think I've got to hear both sides. I think the fastest I can do this is y'all get me proposed orders no more than 15 pages by 5 o'clock Friday. And let me work on it this weekend. And try to get out something as early next week as I can.
Your Honor, if I may, it's Mark Richard. I was lead counsel on the mediation, and I'm sure Mr. Wells will agree. When we're off out of court today, we can still talk about these other issues amongst the parties, but we'll surely comply with your schedule.
I would be delighted if I got an email about 8 o'clock tonight saying y'all had resolved your differences.
We'll try to send it, Judge. We'll try to send it.
So let's just, y'all be back tomorrow morning at 8:30.
There, Your Honor.
My present thinking is I'm going to need proposed orders from both sides by Friday, 5 p.m., no more than 15 pages, so that I can work on that and get an order out as soon as possible.
Okay. We'll do, Your Honor.
Anything further today?
Great, Your Honor. No, thank you, Your Honor.
I'll see y'all at 8:30 tomorrow morning. Great, thanks.
Yes, sir.